Thank you all for coming on a normal Seattle day. There are seats up front if anyone wants to move forward, and no one's going to bite and no one's coughing on you or anything. I can guarantee that right now, so that's good. We have a pretty full day for you. I think it'll be pretty interesting. I'm going to just do some housekeeping things first, sort of tell you what to expect. So I think the next slide, I don't know how I tell you that, but let's see how this works. So first off, I want to thank our sponsors, Vera Health in the back. Go visit those folks. Thank you very much for sponsoring that. And Karam Health, who we've been working with for a little over a year now. So thank you both for helping us put this on. I think it's your work and your support that helps us be able to bring folks together. Also want to, the next slide, want to recognize that, we're on the land of the Duwamish people. We want to honor and thank them and give them gratitude. So thank you for that. And now some housekeeping items. Next page. Yeah, there you go. Restrooms are on this floor. There's also, they're non-gender restrooms, so they might wig you out a little bit. If you want one that has a gender name on it, you can go downstairs and get those. There's also a very cool quiet room, which is off to the left over here, big circular thing. If you need quiet space, you need to make a phone call, whatever, that's a pretty cool area as well. For people who are on virtually, you're on mute, so you don't get to talk. So if you have questions, put it in the Q&A. Someone's going to monitor that, and we'll try to get to all of those. If we don't get to them during the speaker doesn't get to them, we'll try to answer them afterwards, for sure. And then there's a big microphone up front. It might feel like you're a little close. So when you actually go to ask questions, if you talk into the microphone, the people virtually will be able to hear you. If you talk from the back, there'll be silence for them. They won't know what you're talking about. So that's great. And then afterwards, we'll send out slides and information. I think we'll actually have most of this videotaped. Is that right, Teresa? Okay. So that you could, if someone was unable to make it, they can get, a copy of it and go from there. Next slide. So just a little bit about the Alliance, and I'll talk more about that later because they keep letting me talk. So we do sort of three big things. We publicly report. We just did our 19th community checkup last week, looking at quality, equity, affordability. You take that public reporting and then you bring groups together to actually do something about it rather than just admire the data. And then you really, at the end of the day, you're trying to drive market change, and that's sort of what we're talking about today. How do we bring a balance into both quality, costs, equity in a way that'll support the market? And you can see on the left a lot of things that we're working on: low-value care. How do we mitigate pharmacy costs? How do we continue to promote primary care, making sure that everyone has a usual source of care? How do we help people navigate to the best practices? All these things that we've been talking about for years. But I think what we want to do is try to make those real and functional as we go forward. And then next slide. Lots of links. You can go to our website and find out other events that we may have. We've got a couple more that are coming up relatively soon. For Alliance members, we have joint committees. We love to get people involved, and sign up for our newsletter so you always keep abreast about what's going on in Washington and with us, and I think that'll be great. The next slide, let's just talk about the agenda. So I will stop talking soon, I hope, and we can get to our good speakers. So Dr. Vey came all the way from Hopkins. She's a national expert on medical economics, so you'll be able to ask her all the questions that you really want to ask a good academician, and that'll be great. We'll have a panel that will meet with and talk about some of those things, moderated by Jim Freeberg. The next slide, We'll also break out into another panel moderated by Dr. Zerzan Tool and with Vera and the city of Kirkland and sort of what their journey was like. And we'll talk to you a little bit and show you some of the stats from the community checkup. We'll break for lunch because then people can talk, and that's part of the reason that you convene people together so they can have those conversations. So that'll be good. And then the afternoon on the, yeah, there it is. It's great to have Cora with us from 32BJ. They are a trust of 200,000 members, and sort of their journey in terms of dealing with some of the costs and functions there, how they impacted their union membership in a positive way. And then some reaction to that from more local folks. And then really happy to have Sean Greminger come from the National Alliance of Healthcare Purchaser Coalitions, and he came from DC. So his slides may have changed after they came last night, but we'll see how that goes. But hey, hopefully he's updated them. Like, he'll update them at noon, I guess, and we'll see how that, how that happens. So without further ado, I'd like to have Dr. Bay come up. She has written in Wall Street Journal, Health Affairs, JAMA, multiple other publications like that. I think when you think about value-based care and what the data looks like, I think the people that start thinking about it, they go, well, we got to have Dr. Bay come and talk to us. So really happy to welcome you up here, and let's give her a little round of applause. They will advance your slides up there, and you can advance them here.
Thank you so much. Thank you, Joe. Thank you so much, Joe. Thank you, Denise, for everybody for having me. It's really an incredible honor, coming from the small DC to this big, beautiful state. Feels like a real blessing. And you might think the winter is gloomy here, but as Joe said, it's hurricane every day in Washington, D.C. People keep asking me, do you still have a job? Have you been fired yet? Literally, at Hopkins, think about, we are the largest academic contractor with USAID. And if you are following the news, more than 2,000 people have been fired. And we are also the largest recipient of NIH funding. And I have many friends working for HHS. So, but anyway, it's a true blessing to be here. Thank you very much. So today's topic is what's next for self-insured purchasers. This is really based on my research and my view. So, it's limited. So I want to put the caveat here. Great. So first of all, we have to be on the same page that healthcare is extremely expensive, right? If you look at the right-hand side, this is the price change for common consumer goods from 2000 to 2022. What's this on the top? Hospital services, right? What's the bottom? TV, toys, computers. So why is that? Medical care services is not too far, right? Hospital service and college tuition, textbook, medical care. Why hospital service so expensive? And that is actually the main reason we're paying so much premium, right, as purchasers. We can leave the question a little bit later, but think about, what's so unique about the hospital services that make it deviate from many other products and services, so expensive. So it's more than 200% from 2000 to 2020. And then on the left-hand side is a CBO report, Congressional Budget Office report, showing that nationwide, the price for hospital services, this side, hospital services, is about 2.5 times on Medicare. For physician services, it's a bit lower, right? It's about 1.3, 1.4. You might say Medicare price is not accurate, but anyway, we are seeing a pretty large gap between what we pay as purchasers for hospital services and what Medicare's pay, okay? And that is the main reason for the high price. So here's our study published in the International Journal of Surgery with Marty Makary, who's a newly minted FDA commissioner, who was my colleague at Johns Hopkins. So we used the price transparency data from hospitals, and they're among the 22 CMS designated shoppable services in hospital. There are 22, it's 75 total. There are 22 in surgery. So we look at those 22, and we found, this is just a part of the table, but we found that the median negotiated price, look at the middle, this median negotiated price column, is much higher than the Medicare rate. But that's not the real story. The real story is if you look at the IQR, interquartile range, we're seeing, for the first row, we're seeing more than $6,000, right, for the removal 1 or 4 breast growth. So $6,000 is more than 2 times our Medicare rate, $2,851. Are you following? So we're showing that more than a quarter of hospitals in their commercially negotiated price, they're paying more than twice of the Medicare rate. If you keep going down, it's very similar. And then we move to the right-hand side, the second to the right column. We're seeing P10 to P90. That means 10th to 90th percentile. So we have about 10% of hospitals with their median negotiated price for that whatever procedure is like 10,000 versus 2,850. Do you see the gap? It's about 3 to 4 times, or even more than 6 times our Medicare rate. These are commercially negotiated price paid by purchasers, actually coming from premiums. And that's not a rarity, right? And then we look at radiology services, very similar with Marty Makary again. Radiology services is a shoppable one, 13, and then we're seeing median negotiated price, 813 versus 139 Medicare, and then we look at 10th and 90th percentile. It's almost 10 times. Are you following? Right? So look at the second one, MRI. So the Medicare pays $446, but there are 10% of hospitals in the United States are paying more than $4,200 for the same MRI service. These are not surprise medical billing. These are commercially negotiated price paid by you guys, by purchasers in routine business. Then the next one, we look at the within hospital insured payer. So for example, we're looking at University of Washington Medical Center, let's say. And they probably have many different insurance companies. Let's say within Blue Cross Blue Shield, there will be 7 or 8 different plans administered by Blue Cross Blue Shield, right? That's what we call the same hospital insurance company pair. What we found is within the same pair, there are huge price variation. So on average, we're seeing about 1.2 median price gap, but then you look at the right-hand side, 6.4, 4.8. Those are gaps. There are at least 10% of hospitals having this kind of more than 5 times or 6 times price gap within the same pair. So let's digest that. For example, I am Blue Cross Blue Shield Plan A with contracting with University of Washington Medical Center. I'm paying $100 for a given service. But then another plan, Plan B, also under Blue Cross Blue Shield, contracting with University of Washington Medical Center for the exactly same service, paying $600. Okay, within the same hospital insurance company pair, different plans are paying different price. So what does that tell us? A lot of purchasers are placing their money on the table, right? Because the exactly same company, another different plan can pay much less or much more than a given plan. So this huge price variation is abnormal. I want to make sure it's abnormal in a competitive marketplace. Can you imagine paying a Tesla or paying some kind of other cars with different dealership, you're paying 6 times different price? No way, because market competition does not allow that to happen. So we're seeing this very abnormal phenomenon. Let's keep going. And then let's look at the cash price. cash price is paid by people, by two types of people, right? The first type is just people don't have insurance, they have to pay cash. The second type is for people who have high deductible plan, who choose not to pay using their insurance, but then using cash, maybe it's cheaper. So we cannot differentiate, but we just look at the cash price. What we found is, look at the numbers in the brackets. Sorry, it's again with Martin Makary. And he actually mentioned this is his favorite paper in his career. So we look at the bracket. We found that for common shoppable services, it's about half, 56, there's a percentage. Around half of hospitals have their median negotiated price almost the same as cash price. So cash price is similar to the median negotiated price. Then if we move on to the second to the right column, this is for cash price less than all commercial price. So we're having about 15% to 20% of hospitals setting their cash price lower than any of their commercially negotiated price. Then we have to ask why. Why is the unilaterally determined cash price, right? Unilaterally determined by hospital, lower than the mutually negotiated commercial price in many cases. This is bizarre, and really defies our belief that a commercial, insurance company really, combine purchasing power to give us a low price. And on the right-hand side, it's just cash price equal to the minimum commercial price. Many hospitals set their cash price as lowest set the cash price same as the lowest commercial price. So far, what's our conclusion? Again, many purchasers are placing their money on the table. Our TPAs are not doing a good job, right? And we are not getting the best deal in town. So let's keep going. You might say all these results are based on what? Shoppable services. So there are many, many services that are not shoppable. Then we look at this with two researchers at University of California, San Francisco, and we look at the trauma activation fees. These are the fees incurred when you take patient to a trauma center. So these patients are most cases are not even responsive, so you cannot shop. But guess what? If you look at the cash price and the negotiated price, ignoring the brackets, you see among all these four different types of trauma activation fee, cash price lower than negotiated price. Again, hospitals are not really giving better deals to us, purchasers, using insurance. Next slide, please. Okay, and now let's look at a different side if they provide the same service. So this is a paper we published last year, 2023. We look at, if you know Michael Chernos from Harvard, and he's a chair for the MedPAC. So he's really into this paper. We look at the facility fee paid by commercial purchasers for colonoscopy between hospital and ambulatory surgical center. And the price gap is huge, as you can see from the chart. There are 3 different types of colonoscopy, and we are seeing more than half of price gap if we take the baseline as the AIC price for colonoscopy. Again, it's the same service paid by different sites, but eventually coming from the premiums, right? Coming from premiums paid by our employers, our plan sponsors, and the workers, our members. And there are many, many different tools now available coming from the price transparency data. If we're familiar with that, President Trump, the first 1.0 signature work is this price transparency. Now we have many free sites offering information based on the price information disclosed in compliance with the rule. So this is from Johns Hopkins. So you can just go there, it's a free site, And then we click Washington, so you can see the whole Washington for one of the 9 different procedures. You can see, what's the Medicare rate, what's the commercial median rate, and how much you can save if we implement some kind of price gap, right? And we can look at, also on the left-hand side, we can see any given metropolitan area. So that's just one example. There are many different tools developed based on the price transparency data. Okay, great. Hopefully now we're on the same page, the price is really high. We have to ask why, and then we can solve it, right? So why price so high is from Congressional Budget Office. I use their work because I was a visiting scholar there at the Congressional Budget Office from 2022, 2023. So I admire their work. People might argue that sometimes their work can be biased, but I think people are really trying to do a good job there. This is a conclusion which I agree. They said there are 4 different reasons why we're seeing such a high price paid by providers to commercial health insurers, especially for the hospital services. So number 1, provider market power. We agree, right? Providers are very powerful. Then consumers limit the price sensitivity. Why? If I'm insured, I don't care. You want me to go to a hospital for MRI versus the AIC, I don't care, because I cannot save, right? Why should I care? And then the insurers limit the price sensitivity. If I'm an insurer, I would love to have medical spending go up, right? Because my premium, my commission, my revenue is based on spending. The nightmare for me would be medical spending drops. That'd be terrible. Where does my revenue come from, right? So that's the insurers limit the price sensitivity. Finally, there are employers limit the price sensitivity aspects. Many employers still don't really recognize that, how much they can save. I think Denise and colleagues know best on this. So overall, these are the 4 reasons. But to me, I want to dig a little bit deeper. I want to today take this great opportunity to just discuss those inherent structural challenges faced by all of us. So number 1 is diversified preferences of our employees, our workers. It's really, really difficult to satisfy all of them. If we are paying attention to the recent high-profile lawsuits, we would know, right? Johnson & Johnson, Wells Fargo, Mayo Clinic, you cannot satisfy all of them, and some of them are going to sue you. Especially now with I believe it's the Appropriations Act, they make the ERISA requirement a little bit more binding. So they can sue you, and you're going to pay them a lot. And at the end of the day, you cannot satisfy all of them. Some of them are going to say, you did not do a good job fulfilling your fiduciary responsibility, so we are not getting the best deal. I'm going to sue you, you're going to pay me. This is a really tangible and I would say urgent legal risk facing all of us, inherently coming from the diversified personal preferences. I don't think you can solve that easily. I don't think you can solve that easily. Second one, no meaningful market power. You might think you are big, but guess what? You are nothing in the eyes of your local hospital, right? How much? So just calculate the patient volume brought by you to the local hospital. Like what, 2%, 1%? They do not care, right? So you have very limited marketing power when you go to a negotiating table as an entity. You go there and say, I'm not happy, reduce the price. They don't care, right? Number 3, TPA distorted incentives. So third-party administrators, many of us use, I think I mentioned briefly, they have no incentive to make the price go down or total spending go down. Why would they do that? If I'm a TPA, I would hate that. I would love to have higher and higher spending as long as I capture you guys. You don't leave, right? You are still my client, and once you are my client, I want the spending to be high. So I can take more cut, right? That's just this distorting incentive there. Finally, policy obstacles. There are policies that make hospitals bigger and make the competing alternatives disappear. So that's really out of our control. And that actually adds to our high spending. So these to me are very inherent structural problems. So how do we do that? The solutions? Number one, I think we have to combine power. Because inherently we talk about this low market power, right? So with combined power, then we have to do some direct contracting to get rid of or mitigate the distorted incentive issue with the TPA. And then ICHRA, if you are gonna sue me, guess what? You take the money and leave, and you do your thing, and I'm out of this, right? That's another way to deal with this lawsuit, legal risk. And then finally, try to change some government policies. Let's talk about it one by one. This is a paper we published in 2021 and has been widely cited. All these people are my colleagues in Johns Hopkins. We look at the self-insured employers' market power as compared to hospitals on the commercial market nationwide. Guess what? There are no more than 3 among thousands of marketplaces where individual employers have any meaningful negotiating power. The exceptions are like in Michigan, some places, all the employers are from the Automobile Worker Association. Those are very, very rare exceptions. In most markets, purchasers don't, even unions, don't have meaningful market power as compared to hospitals. Then the next slide, and we also did a case study. We look at Colorado. So Colorado has a peak alliance. Colorado has many ski resorts, and then they have really, really limited negotiating power. I'm employer there. So they formed a peak alliance, but unfortunately already stopped. So use the data, historic data, we look at the price negotiated by peak alliance, we found about 15% decrease in the price with the hospital, especially with the hospital. So that tells us if you combine power, and if the combined power can become a challenge to the local provider, you have a chance. You have a chance to lower the price. Become bigger, like hospitals are doing mergers acquisition, and we do combining power, the same idea. So this might be a promising approach. And the second one, so that's the first one, right, combining power. Second one, we'll talk about direct contracting. This was just published yesterday. I told them, I'm going to talk to Washington. They know Denise, House Affairs Forefront editor board. They're like, okay, we're gonna put that out. So yesterday published. So we talk about employer, literally, thank you, Denise, employer-provider direct contracting practice and policy. So sir, I wanna, if you can, would you please go to the article? Yeah, I wanna briefly talk about 2 things we mentioned in the article. As researchers, we are really frustrated, by our purchasers' lack of ability to drive down price. So why don't we do a direct purchasing? Sorry, yeah, great. So this is just the opening, right? Let's see if you agree with us or not. So can we make it a little bit bigger, sir? Yeah, thank you very much. So we go to the second paragraph. Sorry, it's good. So we are seeing that TPA, sorry, a little bit above. Sorry about that. Yeah, thank you. Perfect. So see if you agree. So the TPAs have a misaligned objectives. While the employers seek to provide care for their workers at a low cost, employers here is interchangeable to purchasers, okay? So purchasers seek to provide care for their workers at lower cost. Most TPAs aim to maximize their profit, with revenues typically tied to client overall claims. So this is really our main concern. TPAs are not our friend, right? TPA have a misaligned incentive with us. But in the meantime, employers have limited ability to assess TPA performance. We cannot do that, right? It's really hard. The combination of misaligned incentive and lack of control, lack of performance control, and performance assessment create a complex and opaque cycle. So our providers submit bills for inflated charges, and TPA told us we have a discounted rates, and then collect the fees based on the spending, and then we think, okay, very nice, and we got a lot of discount, and the result is our premiums keep going up, right? So 7% increase from 2023. Now we are paying more than $25,000 I believe that's for average family, yeah. So here we're, again, I mentioned this already, right? High-profile lawsuits. That's why I think our conference so timely, and I got such a privilege to talk about this. I think the legal risk is going to be more and more threatening as we move forward. Yeah, especially Johnson & Johnson. I don't think the decision's out yet, right? It's still it's pending, but depending on the result, even if employers win, I still think more lawsuits will come up. Yeah, great. So then we talk about what direct contracting. Let's move down, and we talk about a lot of details. I hope you will have time to read it. But our punchline is that at the end, we do believe that this direct contracting has the potential to help us, although we are facing a big problem. That is, we have to narrowly confine the provider network, right? If we're doing direct contracting, I'm direct contracting with my local providers, some small providers, and then I have to ask my workers to go there, they might not like it, especially if my labor force is dispersed geographically. They won't like it. But anyway, we still think this is promising, and it can be between employers and providers, can also be between the workers and providers, like direct primary care, direct specialty care, etc. So direct contracting is one facet of a broader shift, we believe, toward direct access paradigm. So direct primary care, direct special care, direct medication, so that the workers can get non-discriminatory rate, basically like cash rate, right? The provider gives the same rate to everybody, and then this bottom-up demand might give us a chance. That's our belief with this direct contracting. At the end of the day, many purchasers might just feel enough is enough. The legal risk is too much. We'll just either we let the employees do their own thing, which is my next point, ICHRA, or we're narrowing network. And you have to take one, right? There's no free lunch. You have to take this, direct contracting lower price, or you have to pay more by yourself. So there has to be some kind of trade-off. Yeah, let's go back to the slide. Thank you, sir. Next slide. Okay, so the next point I'm talking about is ICHRA. So ACRA has experienced high growth recently. So we're seeing 64% increase in the number of employers offering ICHRA from 2022 to 2023. And we're seeing growth in the applicable large employers doing that, and then total enrollees and the size of businesses. So although ACRA, so I hope everybody's familiar with this, right? So you give the employees a ability to reimburse their premium if they go buy on the individual market. So you guys buy the insurance plans, and I'm going to reimburse you, but then I don't have any legal risk. You're not going to say that I did not do a good job managing the benefit. So we are seeing an increase on that, and I think probably Trump 2.0 is going to push on this, because this is their initiative in the first administration. Okay. Now let's move on to the fourth point. So the first one is combining power, then direct contracting, ICHRA, and then now we move on to the last point, move the policy needle. I see Sean's here. Sean, 340B, I put the top. Yeah. Yeah, these are, no joke, these are really the needles we can help to indirectly help us. So it's not like, okay, we're going to cap the price. But let's see, if we correct the 340B program, I was everybody familiar, right? 340B program? Yeah, we can really weaken the hospital power and then reduce the incentive to increase the medication price we pay. And then taxpayer subsidies, this really, my work on nonprofit hospitals, they purchase providers, some physician groups. Immediately, the physician group don't need to pay property tax. They become nonprofit. And then they are competing with individual physicians, independent physicians. There's no way independent physicians can match them, right? So the independent physicians got absorbed by the larger systems become bigger and bigger, and our price become higher and higher. That's how the market consolidation works. And then site-based rates, like the ambulatory surgical center versus hospital, the facility fees. We are right now having a big fight in DC, Sean knows this best, with the set neutral payment issue. We're trying to even make Medicare pay the same price between hospital and ambulatory surgical center. And next one, CON, POH, the physician-owned hospitals are banned from expanding or establishing, which really limit the competitiveness of the hospital market. So I believe we should get rid of the ban, and then certificate of needs law. There are a lot of anti-competitive protectionist laws there to help hospitals to expand their power. And then we have provider tax. If you're following the Medicaid fight, in North Carolina, the hospitals are paid by Medicaid program at the price of commercial rates. So basically, government is channeling the money to the hospital. Guess what? Once the hospital got the windfall, what do? I'm a hospital CEO. I got the windfall. Do you think I'm going to control my spending? No way. I'm going to make my cost structure even more bloated. Then I'm going to keep increasing the price for commercial payers. Right? Beyond that, remember, Medicaid is going to pay me based on my average commercial price. If I increase $1 my commercial price, not only I got money from you guys, purchasers, I also got $1 more from Medicaid program. So these are terrible policies. On the surface, helping patients, but actually hurt all of us, purchasers. So these are just examples. They all contribute to mergers and acquisitions, and eventually come back to our first slide. Very, very expensive hospital pricing. So high price, regulatory capture, corporate welfare, and suppressed competition, and we end up in the current situation. So, I believe if our goal, if this is what we want an affordable, dynamic, innovative, and diversified healthcare, then we must do these things. So next slide, please. So we have to combine power. Right? If we feel there's a pathway going forward to build a meaningful negotiating power in our local market, let's combine power. Then let's think about direct contracting. If we have relatively concentrated labor force, we have good providers in mind, we can do direct contracting. Or think about ICHRA, if we're really tired of dealing with the legal risks. And then finally, don't forget, our voice is so strong. We can change the needle. We can push for pro-competition, pro-affordability, actual regulatory and legislative changes if we have the will. So finally, I want to say, I believe all of us are playing an extremely important role in changing the dynamic and paradigm of healthcare. It should be our mandate. It should be our calling. Thank you very much.
I can say this.
Yeah.
With direct contracting, wouldn't that be akin to what we did with capitation, and that didn't go very well because employees didn't like the restrictions?
Exactly. Yeah, similar to that. Yeah, so direct contract is very similar to the capitation, but it's going to be involving all sorts of restrictions. For example, if you use primary care, you have to go to these 3 doctors. Right? Then you can get basically free care. If you go to other providers, you have to pay by yourself. I'm sure many employees, they don't like it. Yeah. And then you probably can say, look, if you use medication coming from the direct contracting, free. If you use other channels, it's not free. Yeah, and we wrote in the article, that is the real challenge. Diversified needs and very dispersed labor force. Let's say we have 3 direct contracting primary providers in one city, but then 40% of labor force in another city. How can you make that work, right? It's really difficult. Yeah, that's why from economic perspective, again, no politics involved. From pure economic perspective, purchasing healthcare insurance should be done at the local level. should be done at the local level. That's the most efficient way. Imagine if I live in Washington, I live in Seattle, then I buy my insurance in Seattle. Then everybody does that. Then we become very powerful, right? We mostly use our local providers, etc. So if you ask me, what's the most efficient economic solution would be, let the employees, let the workers go buy their insurance at the local level, maybe individual market, etc. And then that probably is the best way. But let's also remember there's some inefficiencies on the individual market. But if, let's say, individual market is efficient, then we have affordable plans available, then I really think that is the best way. Employers involved or not, let the employees buy at the local level. Yeah. Thank you.
I don't know if I need a microphone or not.
Yeah, I can hear. Yeah.
I think buying on the individual level sounds great, but in reality, it's quite a bit more expensive than employer purchased health care.
Yeah.
So this question is really for the group, maybe by pause. How many here would be interested in a combined employer purchasing initiative that's led maybe by the Health Alliance?
Yeah. So, how many of the purchasers here are interested in combining power, join the alliance to buy healthcare together? Yeah. Yeah. So I really see there's a structural issue, right? It's really our power, even if combined, sometimes limited. But I still think from our research, Colorado, Peak Alliance, we saw very promising results there. Yeah.
We're talking about market efficiency.
Yeah.
And I think we all seen since COVID, the market, in general, healthcare delivery solutions are more dynamic. I'm just curious from your perspective. Talk about hospitals that have a lot of. Where do you see virtual medical care providers in general fit with the whole dynamic? In that now it's a new way of looking at care delivery. I'm just curious.
Yeah, absolutely. Yeah, virtual care delivery and even think about the AI. I think these dynamics are gonna transform healthcare. In my view, these are grassroots, bottom-up demand from these innovative, non-traditional, disruptive providers want to also take a piece of the pie. And on the top, there are very strong forces preventing that, right? Political power, establishment, and all the incumbents. They hate all these new AI virtual care providers. So we're gonna see this kind of fight. But eventually, I do believe the two forces are unstoppable. Number one, those innovative providers. They're not gonna be told to do nothing. They try to compete, right? They try to establish themselves. The second is on the buy side. So we just talked about sell side. On the buy side, there will be employees, some workers, they don't wanna be confined with the current regime. They wanna use their own money to do their own thing. And for example, I heard some workers saying, why don't you give me $25,000? Let me buy. Or something like that. They want to have the control over that, and they think they can do a better job. And these people are the users of those innovative providers. If you look at I think RFK Jr., so in his talk, he's talking about innovation. I don't know the political dynamics with RFK Jr.'s HHS, but overall, I think they are trying to more cater to this new innovative force. Try to see if that can create any political will that can help fend off the current incumbent. Those very, very powerful forces. Yeah, thank you. But eventually, I do believe technology will create earthquake, right? Yeah, if we are seeing things such as price dropping rapidly, but not healthcare, we're gonna ask why. If you think about how much it costs to store a megabyte on internet, we're seeing like exponentially right, a lower price over time. But we're not seeing that happening in healthcare. Why? Now with the AI, with technology, I think the force is non-stoppable. Thank you very much.
I've got one for you. By the way, thank you. Wonderful, comprehensive
Thank you.
presentation. The 4 solutions you gave, I think 3 of them seem like long-term needle movers. One doesn't look like the rest, though. So we mentioned the individual market with ICHRA. I see that eliminating legal responsibility, liability from employers and allowing for freedom of choice, but I don't necessarily see that lowering cost and gaining market efficiency and as a long-term solution. So how does that functionally happen? Why did you include that in those 4?
You mean ICHRA, right? You mean
ICHRA.
ICHRA including the 4, right?
ICHRA, ICHRA. Yeah.
Yeah. So that comes from my belief that the most efficient way to purchase probably is at the local level. For employers, let's say I'm Wells Fargo, I have such dispersed labor force. Let me design a healthcare purchasing regime to meet the needs of so many different people in so many different places is really, really difficult. That's why I think ICHRA might provide a promising channel for employers to get rid of the burden and let the employees choose. But at the end of the day, I believe the stop loss, insurance, reinsurance has been bought by the employers to help protect the most vulnerable, high-risk individuals. Otherwise, it won't work. Yeah. Before we do any reform, I think we have to make sure the most vulnerable folks are being protected, not being discriminated, before we do anything. Yeah, that's why I'm totally for government subsidized reinsurance. Yeah, but thank you. That's just for me the combining the power thing is difficult. But guys, what if Trump can't do what he said he's doing? Remember, he said he's going to get rid of individual tax, like income tax, and everything coming from tariff. If he does that, then our problem solved, right? We no longer have tax exemption problem. But yeah, it's inherently that's the reason, right? Because of tax exemption of our spending on healthcare, that's why we have this traditionally way of purchasing healthcare through employers. Great, thank you for the great question. All right. Okay. Yeah.
So with the ICHRAs, what is the breakdown of the plans between bronze, silver, gold, and platinum? We're concerned as an industry, people are going to choose the catastrophic bronze plans, and that would not be good for healthcare, generally speaking. Do we have the breakdown of how people are choosing the plans in the ICHRAs?
Yeah, I don't think the rule had been developed to that level. So right now, I think you can only offer one type, and that's a problem. Ideally, if I can design, I would say, here's let's say $20,000. And you take it, if you want to have catastrophic coverage, go ahead. And then maybe the rest you can put into HSA. Or if you are more risk averse, then you buy a high premium plan, and then you have less left in your HSA. I think that'd be the best solution. Then we can ensure diversified needs being met, right? And at the same time, as an employer, I'm fair to everybody. I think that's what I believe the Department of Labor, they're trying to do something regarding that. At the end of the day, ICHRA or HSA, they are the same from the tax treatment perspective. Yeah. Thank you. Great question. All right. Thank you very much. Again, this is truly an honor to be here and learn a lot from you. I'm looking forward to learning more. Thank you.
And we're going to ask our panelists to come up, and we'll just get set up, and we'll start answering some tough questions. Right, Jim? Yeah, okay.
Good morning. No, it's not working. There we go. Hi, I'm Jim Freiberg, the moderator of this panel. As the panel comes up, there is a question for the audience. On the back of your name tag, we have a poll here, a Slido. If folks can scan that from your phone, and then you can put your answers in to help inform the discussion. Okay, so good morning. So my name is Jim Freeberg. I am the executive director of the Patient Coalition of Washington, which is an advocacy alliance that I started about 5 years ago to bring the patient perspective to policy discussions at the state level in Olympia. We just are a policy advocacy alliance, but trying to bring the patient perspective. And I think we had a really good presentation to kick us off. I appreciate that on price. But we all know price is just one thing that we think about in healthcare. It's something that's really easy to measure and compare, but it's not the only thing. And so our topic here today is about value. We're going to dive into that on this panel this morning, and really what everyone's at is driving, a positive healthcare experience for your employees. So we'll do introductions, and then we'll start with a few questions.
Hello again, this is G5 from Johns Hopkins.
Greg Marchand from the Boeing Company.
Drew Oliveto, Washington Health Alliance.
Nancy Gento, formerly of the Washington Health Alliance.
And I'm Peter Jung with Mercer.
Great, thank you. So first question is going to be for Drew, and then we'll have the others respond. And Drew, you have a particular definition of value in healthcare. How do you define healthcare, value in healthcare? And then I want the others to respond if this definition is widely accepted or
I'll
not.
give you a nice long answer to a short question. Can you hear me okay? Okay. So when we're, part of the conference today is talking about what's the balance, right? What's the right balance in terms of things? And traditionally when we were taught 30 years ago about what's healthcare value, it was a pretty simple equation. It was quality over cost, right? And we do that when we buy a car, right? Nice luxury car might cost a little bit more, but if we think we need a luxury car, then, gee, that's great. And my wife, when she bought her car, said, I need a Subaru, I don't need a Lexus, and it's cheaper, so that gave her more value. And we can sort of think about the same thing when we talk about healthcare, because, and it's going to depend a little bit on who you are. If I'm a typical consumer, my definition of quality is really different than if happen to be me. I'm a little bit more educated consumer of healthcare. I'm looking at, did they do the right exam? Did they order the right test? Did they check all the boxes? The typical consumer, did I get my appointment? Did they treat me nice? Did they look me in the eye? Things like that. So quality is going to be a little bit different that way. And I think as we've evolved that equation, we have to add a couple more things to it. Because you can have really high quality care. I can do surgery on this person's knee. They recovered really well. They were able to walk, the next day. Fantastic. But was that an appropriate service? So there has to be an appropriateness component to that. So if they didn't need the service, then the quality is not very good. If they did need it, absolutely, that's great. And then I think the last piece that we were talking about in terms of the consumer is, do they have access? And when we look in our state where we have a lot of rural areas, where we have a lot of low-income areas, and frankly, I think most of the commercial market right now, getting access is difficult. So if you don't get access in a timely way to the right provider, that's going to be problematic as well. So I take all those components together, and you're going to have to make your choices. I would say, and I'll ask Greg, so even though I'm not allowed to ask questions, but I think I know your answer. When you think about what's value, how do you balance the quality versus cost? And my guess is you value quality over cost, and that might be okay. And for me, I could say the same thing. That guy doing your knee surgery, because I had knee surgery back in June, I want to stop hurting. I want to feel better. I don't want complications. Would I pay more for that? So I don't have to get, resurgery? Absolutely, all day long. So that, you might say, well, the cost was really high, but overall, the total cost is probably less.
I totally agree with you.
I've listened to you before. That's
You
why.
have. I mean, our strategy is quality first, quality second, quality third, because everything that doesn't happen clearly offsets the cost of paying a little bit more for great quality. So, I mean, I agree with everything you just said. And I would also say it works.
And also that you shouldn't do things that you shouldn't do. 'Cause that's not
Well,
high
you
quality.
shouldn't, right.
Right.
Yeah, I mean, I put appropriateness in the same bucket as quality. I totally get your point of how you're pulling that out, but I mean, how can you say it's high quality if it shouldn't have happened? It's not.
Right.
It shouldn't have happened. I mean, just to put a fine point on this, my current costs are at 2014 levels. And that's not asking employees to pay the difference. So my costs are at 2014 levels. I'll just repeat that because this works if you do it
Absolutely.
right.
Greg, I think Boeing is probably a pretty sophisticated purchaser. I mean, is this understanding the widespread, you think, throughout the purchaser community in terms of what value is and how, let alone how to achieve it, but that starting place, when you talk about avoiding unnecessary care, do all employers get that?
Well, no, they don't. But I also, I mean, I want to acknowledge at least one other thing Drew said. I can't define value for everybody, and I don't expect everybody to define value the way I do. I can just say, defining value the way I do, if your goal is to deliver great care at an affordable price, it works. For my non-union population, we have not increased what they paid. We're at our 5th year in a row now. And this next year, and I'm embarrassed, terribly embarrassed to say this, may be the first year that I have to charge my businesses more. So I've eliminated trend completely to employees and the business 5 years running. It's simply pulling out waste. And I still don't think we're doing good enough. We're just doing better than what most people do.
It's the whole panel. It's not. But I guess. Yeah, Peter.
I work with a lot of technology employers, and unfortunately, their costs are a lot higher than they were in 2014. And I think tech has been it's been interesting the last few years, right? In terms of the kind of the shift in the economy and all that. And I think one of Dr. Bai's slides really resonated with me, the side of care price differentials, because I did that with one of my clients and said, your costs with freestanding clinics versus facilities, like there's sometimes 10 times difference. Like if you steer people towards these providers, you have a lot of money on the table. And they said, we don't want to inconvenience our people. They're willing to pay more for convenience. We have a lot of people in high deductible health plans, and they're willing to pay more for convenience. And I went into that meeting excited, thinking I'd be able to help my client save a lot of money, and they just said we're still not there yet in terms of disrupting our members. So, yeah. So in terms of tech, I think they're always looking for the first employer to really be that disruptor, right? And then they want to be fast followers. But
I'm gonna add something if you don't mind.
Yeah.
See, I think that's okay. So what this is, and I'm not being critical of this discussion, but this is a very narrow discussion on the cost of healthcare. Now, we're a company where we build stuff every day. So, I look at it like from a total productivity perspective. Healthcare, direct healthcare is just a portion of that. Now, I mean, I actually don't have an issue with what the tech companies decided in your example, because they've decided what's important to them. And they're placing a different priority on the direct cost of healthcare. Now, I think that makes it harder to have a marketplace that works effectively, but they've decided what's important to them. And, they just happen to have different goals, which I often think we often miss in, what's the purpose of what we do and why we do it when we think of it too narrowly. It just, my opinion on that.
And my guess is those tech companies, their trends are still going up, right? Because you didn't really change the dynamics in there. You know, Boeing does some direct contracting. Boeing's committed to primary care. You know, you're really driving people into services that are going to be more efficient and give better quality, and that's probably why your trend is flat, right? We did an exercise with our health plans this year where we asked them a question, and we said, come talk to our purchasers. Here's the question. Save us 10%. Pretty easy, right? Should be, right? People are laughing at me. They came in and they actually had a plan. They were really thoughtful, and they said, well, here's how we can save 10%. But one of them, but three, maybe even four, were getting increasingly sophisticated on how to do that exercise. And some of it was letting people have the choice, right? Hey, they just want to pay more. Well, a high deductible plan is sort of regressive, especially to low-income folks. So it's really hard to make that one work. Tech companies, you know, your high-income, you know, earners probably is going to be okay. But plans came and they said, we've got alternative health plans. And three of them actually had the same sort of model, which is no deductible, no coinsurance, right? I got a head nod over there. And what you do is when you want a service, you get to shop. Now, they don't do it all the same way, which I have a little problem with. They also don't drive people to primary care, which I have a little problem with. But the shopping part is pretty interesting. They say highest quality, most efficient providers. So for instance, you know, you're getting something at an ASC versus a hospital, you know, you'll know, and your costs will change. So you can spend $300 for whatever that procedure is at the ASC and $2,000 at the hospital. And you get to make the choice. You want to pay more? Go pay more. But that's how that, so it's basically a copay plan. It's pretty fascinating. I suspect we're going to see the evolution of that type of product more often, and my friends from health plans are nodding their heads too. So I think we're going to start seeing that. That generates a little bit of competition, I would think, because you want to be the one that people choose. And I think if you're $3,000, you're not going to be the one versus the $300 one. Could be the same provider at a different location. It might be $3,000, right? So people can make that choice because that's sort of their value. Boy, I really would rather be at, you know, this facility versus the one across the street. You know, I don't know why, but they might feel that way.
So Jim asked the question about value, and the ensuing conversation, I think, has been really rich. And I agree with Drew's definition of value, and I just want to pick up on this idea of individual shopping. So I'm retired for 3 years now, and I've done a lot of individual shopping in the marketplace. And I can tell you that it is not that easy, even for someone who understands the system, to figure out how to shop it. So I love this concept of giving choice, and I love the concept of making alternatives available. But I would just say without some guidance and support, that is virtually impossible to do in an open marketplace. I would just suggest that point of view.
And since I've got the microphone, I get to offer my perspective. I purchase insurance for my family on the exchange. My wife works for a small business. I'm self-employed, and her small business doesn't offer insurance. So I've experienced premiums increasing 10% each of the last 3 years. We had Kaiser. We like Kaiser. I chose to leave Kaiser personally because I could get a much better deal elsewhere. So my healthcare is way more complicated all of a sudden, because I'm trying to take care of my 2 daughters' prescriptions and appointments and so forth, and I'm not a Kaiser member. I mean, there's workarounds, but it just points to, like, I'm trying to get a better deal. I'm bearing the cost of that in time and confusion, and I think that's what's going to happen, right? If consumers are told to go purchase insurance themselves, they're going to see these 10% increases that are going to keep coming in. And Greg, you said Boeing's shielding your employees from all these cost increases. So I'm a little stuck here, and maybe Dr. Bai, if you want to offer more, like, are these things both true? I mean, in the sense of you're telling people to go to the individual market, but those prices are going up and some employers are doing better. I don't know, just help us out there.
Thank you. I think two things are always true. Number one, there's a trade-off. There's no free lunch, right, basically. If you want to, like Boeing did, controlling the price, people have to sacrifice some freedom. They have to follow some kind of guidelines, right? That's number one. Number two, someone has to pay for it. If we are like individual not paying, the employer is paying. And then at the end of the day, all the economics argument is based on trade-off. Usually, if you have more control over something, like you spend time doing like shopping, etc., it will spend more time, but eventually you might have get a better deal, whereas the chance is higher. That's why we're seeing on the other markets beyond the healthcare, we are controlling our own money when we buy car insurance, when we buy other things, right? And we take 100% cost exposure. We have skin in the game. We spend time. And there are some losers, some people are just good at that, some are bad at that. That's just nature. So I would say, if we let the nature play out, we will have a very unequal situation. But if we help, like really making it equal, then we need to have almost like a dam build up. We have to build a dam to let the water flow that way. Yeah, it's not there.
You know, I think you also mentioned, you know, hey, Boeing shielded the employees. Boeing didn't really shield them. I think the HR team said, we're going to make a bunch of choices that are going to be beneficial to our business because our business cannot absorb 10% increases every year and stay competitive. So those choices have to be made, and they're not the easy ones, because if they were easy, it would be a free lunch, and we don't get a free lunch. Now I'm just going to use that all the time. But those choices have to be made, and to help steer people to make the right choice, because I think every consumer wants to get the best care. Thank you very much. But how do people choose the best care? Sometimes it's they talk to their neighbor and they say, "Was that any good?" And, yeah, I guess they were nice to me. Okay, that must be good care. Is that enough? Maybe, maybe not. Or are there some other factors that go into that help drive it? And I think if you don't really think about the healthcare costs as part of your business functions, given it's your number two cost for most, is it your number two or number three?
It's
somewhere there.
4, 5, 6. Yeah, I mean, it's,
yeah. So for most, it's like 2 or 3 now, and the fact that it's less for you guys is great. But you're going to put the same rigor on that as you are when you're buying supplies or working with other vendors, and you're going to expect the same results. And when you don't expect that, and you expect a 10% increase every year, you're not managing that at all.
Yeah, and what? Oh, I'm sorry, Nancy. Go ahead.
So I was. You go ahead, and then I have a question back for you.
I mean, my comments were very much at the macro level. I mean, our employees do have to make choices. We tend to frame them in positive ways. So, and I'll give you an example. So if if you take advantage of advanced primary care with us, or you go to one of our ACOs, and you choose that, you just pay less. So there is choice, but because we've looked at so many of these different opportunities that you had up on the screen, we've essentially negated both the cost impact of good choice and the cost to our business. I mean, and I'll give a little plug for the Alliance and the BRIE Collaborative. I don't know, I think I was probably the first employer. I mean, we shut off, well, I shouldn't say we shut off. We required appropriate prescribing and distribution of opioids. I mean, I did that before the health plans did it. I mean, you can still get a prescription. It just has to follow the guidelines. And if you didn't follow the guidelines, you might hear from me. I was telling Drew, we just caught a dental clinic in Tacoma charging for more dental implants than there are teeth. So, it physically is hard to do, but apparently they found a way to bill it and get paid. So this made it, so we were the ones that caught that. So, I mean, part of the, you know, the power of what we can do together, I mean, there's just so much waste in the system. You can really mitigate a lot of the negative choice if you focus on quality and removing waste.
So Greg, that's the question I wanted to ask you and Drew to speak about a little bit, because, you know, I think waste is still an enormous problem in our system. And I wonder if you can quantify how much waste in percentage or however you would want to talk about. You said you have a long way to go, but can you give a number to how far you've gotten? And then are you advising your clients at all about getting rid of waste in the system, which is harmful, very harmful?
Yeah, so you're asking your question in a way that we haven't quantified it, except that I can say, so whatever, you know, whatever your trend is, each employer, I mean, I have negated my trend completely, and that's almost all through one approach to waste or another. And you know, we all define waste a little different. I mean, I view inappropriate opioid prescribing as waste. That's my definition.
And harmful.
And harmful, yes. So if I remove that, then I think I've done a good thing. The really fascinating thing is the only people that complained, I mean, we did this like 10 years ago, whenever that was. The only people that complained about it was the doctors and the dentists. I mean, the dentists hated. I'm like, come on, people. Well, how can you complain to me about? So, I mean, I didn't care. I didn't have one single employee complain to me because it was a safety issue. I mean, that's just one of many. So, I mean, Nancy, you're asking a fabulous question. All I can say is, in 5 years, I've negated whatever trend through mainly removing waste.
That's fabulous.
Yeah, that's a great question. I would say, I think employers are targeting, focusing on high-cost claimants as a particular area where, you know, there's potential opportunities, or if there's mismanagement, and so looking at readmission rates, right? Are there, you know, readmissions that could have been avoided, avoidable ER visits? So, you know, a lot of high-cost claimants drive a lot of the overall spend, right? And so I think in terms of waste and opportunity, that's certainly an area that we're talking to employers about. And then the other one is pharmacy, and that's probably an area of spend that's rising the most quickly for many employers. And I think a lot of my clients are more willing to pull levers in pharmacy to ensure appropriate usage there, even more so than the medical design changes sometimes. So, yeah.
If I may quickly add, you're seeing here, I think it's a trade-off, right? Greg has a rare skill set, and Greg needs to be paid. And the employer have to invest resources if they want to control costs. There's no free lunch. And again, Greg is paid. If you're a small employer, you don't have resource, you cannot hire great people like Greg. But then if you don't have resource, you should expect that your spending has a lot of waste. Yeah, that's a fact.
I mean, that's a really good point, because it's kind of, sometimes it's about talent. I mean, we put as much into the talent of the team that does this. I mean, we trade tactics and strategies with our supply chain team that purchases, you know, products for airplanes. I mean, I've learned from them, and they want nothing to do with what we do because they don't know how to do it. But we have learn from each other. And we've shared best practices, but a lot of it is about talent and making sure you can compete from a talent perspective in these discussions.
And just another plug for the Alliance, right? I mean, I think that's one of the real powers of the organization that you're all a part of, is that you learn best practices from others. And yes, industries and organizations are different, but there are words of wisdom, and we're gonna, I think, hear some journeys later that just, I hope, spark for the group just a nudge of, wow, I never thought about that in my organization. How could I make that happen? So.
I want to go back to the question we posed earlier to the audience. We could pull that back up on the screen, and maybe for the folks up on the panel, just to kind of look and see what the audience wanted to know more about, to see if that sparks anything. But we'll see if that comes up when we get our tech assistants and the screen coming up. Here we go. Okay. So we'll just take a moment here for us all to look at this. So access is one of those big words here. And Greg, you talked a little bit about kind of the choices that it sometimes entail access. I'm curious, do employers kind of understand this widely? And kind of what are some of the challenges that they face when they're working on trying to make sure that there's access for all their...
I mean, that could be a whole discussion. I think together would be ideal, but we do it kind of ourselves, is we need to create more access, especially to things like primary care and behavioral health. I mean, I think that is something that every employer can do. You can't always do it alone, but it's actually not that hard to do it in collaboration with others. I mean, you can partner with somebody like Vera. It's really not that expensive to do. You can do that with local health systems if you find one that is willing to partner. But just like any other supply chain issue, if there's not enough tires, you've got to go find another supplier to buy tires from. It's the same thing. And so, there's a huge problem with access in not just this community, but many, especially for primary care. So we're creating access for our employees. The wonderful thing about that then is then we can we're not trying to control where they go when they need other care, but we can help them find great care. And we have a few years of data on this. Both employees and providers love this, because we've taken a huge additional defect out of the system by getting everybody great specialty care.
And I think there was a comment, when Dr. Bai was talking about sort of virtual care, AI, and things like that. That is another way to supplement appropriate access. I think behavioral health has been a sort of a classic one. We saw that in the pandemic, where 70–80% of the visits were virtual, and and the quality side of that is that most of them can stay virtual, so that's good. Primary care, I think there are populations that they would rather do digital first and not actually, like my daughter, doesn't ever want to see anybody. So she would rather just do, a telemedicine visit, say thank you very much, and only be seen if she has to be seen, right? So I think all of that can help supplement a little bit. There clearly is an access issue on primary care just due to the number of primary care providers. Behavioral health, same question. There's also some inherent practice transformation changes that need to happen, because anyone try to schedule an appointment recently? And anyone get one today? Okay. Yeah, you did.
Yeah.
Right. Right?
It might have been tomorrow, but
Exactly. So 20 plus years ago, we, and I think, Paul, you're in the same 5 years ago. We did 20 years ago, and we basically made sure anyone who called in for an appointment had 3 choices within 24 hours. Anyone. Every day of the week. And it took a while to train the patients because they were thinking that it would be 6 weeks from now. I'm calling up for my physical, and you say, well, come in at 2. And they say, 2 what day? And there's 2 today, and they're like freaking out. And they said, I'm not prepared to do that. Well, can you come in at 3?
I haven't done my diet or exercise yet.
Right. I mean, I overate this morning. I mean, I got, so that took a little siege. It took about almost 9 months for the patient population to, figure it out that you could actually be seen right away. But it also took us about 9 months to even, work our backlog down, understand the dynamics of practice, which haven't changed very much. And you can actually put that into play, and all of a sudden access is really good, but you can't, overfill your practice, right? You can't say, oh, I'm a typical family doc. I have a panel of 2,000 patients. I think I'll have 6,000 patients and see what happens. Well, it's going to be a mess. You got to put your limit somewhere. It's pediatrician can have a little bit more, geriatrician a little bit less. Payer mix, you have to modify all those things, all those details, but you can do that. And then if you're full, and you close your practice. You don't take any more until you need more to fill up the gap. So, we can solve access a little bit with just some dynamics, but I think as we've seen consolidation happen, you've got people that haven't managed healthcare before and managed physician practices that are just saying, schedule patients, because that would be good. And what you get is long waits, a lot of no-show rates, a lot of rework, and a lot of dissatisfaction. And it's the same patient population, and it's the same panel size, and you've just screwed it up. So, and I know, Paul, you want to say something, and there's a mic right there, and you got to stand up, and I'm going to make you talk.
Yeah, thank you. Is this working? Doesn't sound like it's working. No. It's okay. I'm loud.
People need to hear
No, I'll just introduce myself. I'm Paul Burens. I had a 39-year family practice in Kirkland. When I left practice in 2020, I had a third next available appointment in less than 24 hours and a third next available physical exam in less than 2 weeks. And today, I'm a patient there, and it takes 12 weeks for me to get a primary care appointment. So here's the problem with access. I now live in Anacortes, Washington, a fairly wealthy community with supposedly adequate primary care. All of my friends and neighbors tell me they can't get appointments with their primary care, so they go to urgent care. So the audience knows, urgent care doctors make a single decision. Do I treat and send them home, or do I send them to the ER? So they get sent to the ER. The ER doctor has one decision, well, maybe 2. Do I admit them, or do I refer them to a specialist? And is it going to be the right specialist? And the math is primary care office appointment costs, ask Dr. Bai, primary care office appointment costs X. ER appointment costs 10X. Hospitalization costs 100X. So here's the issue. We don't have access to primary care. It's grossly damaged and getting worse rapidly. How do we get out of that?
Can I interject here for a second and ask the audience a question? So we help people find specialty appointments. Does anybody want to guess what the #1 request for specialty appointment is?
Dermatology.
knee problems.
Primary care. I'm dead serious. The #1 reason people call and ask for help is because they can't find primary care. At first, that was shocking to me, and then we just leveraged that as an opportunity. Then we find people primary care, which is to all of our benefit. The one thing on access that I do want to comment on, because I do think this gets often missed with employers, is we need to think about the whole community. And I struggle with this because I can do great things for my employee, population. I mean, my goal, and you guys can all hold me to this, is I want to open a primary care clinic where it's most needed in the state, and I want to prove that we can do it and we can run it for the benefit of the community, not our employees. But I do think, and this is a good, really good part of the alliance, is we need to think about that component of care, because it's I mean, if you think about the wait times we're expecting and accepting, think about folks, the rest of the community. Yeah. Yeah.
Well, I guess we'll take down this slide if that's okay, and then we'll go to the next question. So on the back of your name tag, there's another QR code, and poll number 2, it's asking what's the biggest barrier you've experienced as you've tried to drive value. So we'll let you pop that up. While that's happening, we'll see if we can keep the screen blank. So we'll just have a little discussion here while folks are doing that. Primary care, huge challenge. I did a survey in this fall I looked at websites and called providers and found exactly what everyone's finding. 3 months or more, there's a provider that was taking appointments 11 months out. Websites are widely inaccurate. Providers say they're accepting new patients. You call them up, they have no appointments, and you get no callbacks. And I'm curious if your response, or how you would think about the healthcare system's response to this, because we still have primary care providers as gatekeepers, right? You need a primary care provider so often, even without an HMO, for referrals to specialists. You have urgent care centers popping up. I'm curious, how can we, and maybe talk more about this, as a community kind of encourage this turnaround to happen? What's that look like? And part of the question, or one of the desires for more information, how do we build collective will, specifically on primary care, focusing on this question?
What do you do? What do you tell your clients?
Yeah, I mean, in terms of, a lot of my clients have ordered their employees back to the office, right, many days a week, and convenience is very important for many technology workers, and so there is kind of looking at, are there near-site, on-site opportunities, right, to make it convenient for people, and so, and virtual primary care, I think, I have a client that offers that, and it's been getting some good engagement. I think in terms of, we haven't measured the long-term success of that yet, but those are a couple things, yeah.
I think one other part of that, I think, is a completely different question from an economic perspective of, should we pay more for it? But because, I mean, in the end, it just comes down to revenue. So, I mean, one thing we're willing to do is we are willing to pay more to prioritize primary care in the revenue system. I don't love that, but the payoff is really clear. I mean, even in the few years of data that I have, if you get reasonably good, not even great primary care, but reasonably good primary care, you save money. I mean, it's not that hard of an equation, because a handful of avoided ER visits pays for an enormous amount. So just, you've got to get the priority within the economic system, which unfortunately is revenue. And you can change that if you're willing to do that.
Let me just piggyback real quick. Exactly like Greg said, if you are a primary care doctor, why would you keep practicing, right? You should shut down because you don't have much revenue and you have all sorts of regulatory, administrative burden. That's why we're seeing lower and lower supply. And then we have this higher demand. That's why we have an access problem. We actually have a paper, hopefully forthcoming in Journal of General Internal Medicine. We have a very provocative idea. That is to get rid of, kick primary care out of insurance. Buy primary care just like we buy coffee.
How about buying it like you buy fire, police, and public school? Let the community buy it.
That's also fine, but has to be let the insurance middleman out of this. That's the solution in our opinion. Access means abundant supply, right, compared to the demand. That's the only way to stimulate the supply, in our opinion.
Yeah, I think we, like a year ago when we had this conference, the Milbank Fund, and I can't remember his name, guy was here, and he basically said, you just got to pay more, right? So that's one aspect of it, and clearly there's data that shows if someone has a primary care doc, their costs are less. Our data would show the same thing, about 30% less. So you're right. Just even if you get average primary care, you're probably going to save some money. That's okay. That's part of it. The other part that you mentioned was, we try to refer people to the right place when you do need to refer out, right? And today with consolidation, you now have bought yourself a narrow network. Because whoever you start within that system, urgent care, ER, primary care doc, if they have to always refer within that network, that might be fine. It might be a really high performance, health system, or it may not be fine because maybe they have great cardiology, but wow, you could do ortho someplace else and it would be more efficient. So I think if you're buying primary care, you want to also make sure that they're doing something else to justify that, that value that they're getting, right? And that value is, hey, we need to make sure you're referring to the right, highest quality specialists, et cetera. I remember when I worked at 2 different insurance plans, we had primary care groups call up and say, who should I refer to? I want to refer to the best quality and lowest cost. Give me the 5 names of the cardiologists I should refer to in my community. And I would give it to them. And they said, thanks. Not that we were paying them different on that, but they just wanted to make sure that they were referring to the right place. And that saves a lot of money, but.
So I would just, piggyback on what I love your idea. I mean, I think it's a very intriguing idea to test in marketplaces. I mean, you have to accompany that with transparency, right? Someone needs to know, okay, if it's now an open market, how do I make a decision about that? How do I know what good primary care is? And I think that's the coupling, that's the magic that has to accompany.
Well, I mean, there's organizations like the Alliance that can help with that. There's others in other communities. And maybe since we're kind of focusing on this, I mean, I don't think it's so much just paying more as it is paying differently. And defining what more is, because if you look at it at the macro level, you're probably going to end up paying less, even though you're paying an individual provider more. But pay differently, and I mean, we do this now essentially without claims. And then and talk about the clinicians loving it. You don't have to worry about, I mean, there's still data. Data is really, really, really important. But anybody who is really into this doesn't want to do it without data. You're just doing it in a way where you're not burdensome by the nonsense of the typical claim system.
I mean, I think another challenge is that too often people, I think, don't consider how they would access the system until they need to access the system. So it becomes a more urgent situation than if you thought about where you were going to buy your coffee because you like your coffee at this certain place, and how to motivate individuals to consider their healthcare needs before they actually need it is part of it.
That's one thing with an employed population where you really have an advantage. I mean, we do struggle and are really focused on how do we reach spouses and dependents well, much harder. But it's really fascinating. Every time we have clinicians come into our offices or factories, then enrollment for primary care goes way up. So it's actually, you can really solve for that issue with an employed population. You have to work way, way harder. But if the employed person is happy, usually they want their family to be happy as well. And so it just takes time, but you can really leverage that.
If I may add, okay, on Greg's point, Greg's direct primary care has another benefit. That is to mitigate the risk of the unnecessary referral. Nowadays, many primary care doctors are owned by either hospital systems or insurance companies. So these primary care doctors are used as a gatekeeper or to prevent referral leaks. So their job is to channel the patients to their internal specialist. But in Greg's way, there's no such incentive, right? Because it's direct contracting with Greg. So I just want to make sure that we understand there's a hidden benefit.
I mean, there's another leverage point, and I study this from a little bit of an odd perspective. I think related to specialty care and some primary care, I try to think of it the way Google does. And I'm going to offend somebody by saying this, but it's just bringing buyers and sellers together. Google is really good at that. So if I can bring good sellers, the supply, to my employees, then I've created a transaction. So we're selling something. If we leverage technology, access, transparency, we've just really enhanced that transaction because people can see what they're buying. And they should be able, if that's important to them, to pick a provider that looks like them or speaks their language, whatever is important to them. Then you've created that economic cycle that, in my mind, works really, really well.
And it's free to them.
Yeah.
Let's go to the audience for the last few minutes, and then also pull up, if we could, the answers on the screen from that second slide. So if folks have questions, come up to a microphone or comments. Somebody.
Sure. Is this working?
Push the button on it. There you go.
All right, apparently it is. So I spend all my time talking to health plans about health plan design, unit economics. And I was thinking about all your thoughts. And I was trying to think, for me, when I have these conversations, what is value? And I'm going to give you the four that came to mind. And I'd love for you all to react to it with, are we on track? Is it different? Do you want to double down to any of these? And I think we're probably aligned in many of these. One is appropriateness, and I'll give you an example. So for example, endometriosis. Often women get prescribed surgery as not only their first, but their only option. At $20,000 each, with 3/4 of them being completely avoidable, that's huge, right? Number two is plan design. If you can work to make sure you're referring to high quality, low cost, low facility or no facility fees providers, that should be part of the conversation. Number two is remove obstacles. Remove copays and deductibles, not only for primary, but for specialty. If you have a high quality vendor or provider, get rid of out-of-pocket costs. Copays, deductibles, steer there, right? And the last one is measurable total cost of care. Have actuarial, push your providers as well as vendors, show actuarially validated case match control claim analysis, right? So that's it. I'd love to hear your opinions.
Yes. I mean, I don't think there's any way. I mean, you got all the points. Now I've also forgot all of them. I think the plan design piece, you know, we run into some issues, right? We put everyone on HSA plans that has rules around it. And so now you're gonna have to reverse that and put people on a PPO plan where you can do some of that plan design that will actually steer people. The answer probably is yes. Or you do one of those, you know, sort of an alternative plan. But I think you're right. You want to steer people. I think you can do that with, you know, direct primary care. You can say, that one's free to you. You may choose to go someplace else and have your co-insurance, higher co-pays, whatever, but this one's free to you. And if the experience is really good, and they treat you well, and they talk to you, and then they don't just refer you to somebody else, but they treat you like they were trained to do, right? Because, you know, Paul and I and Rick, you know, we were trained to do a big spectrum of care. I think if we were dropped into a practice today, we would, you know, for many systems, it would be, you have to refer. You talk about dermatology, 20 years, I think I did 5 referrals to dermatology. 4 were because the patient requested it. 1 was because I thought they needed to. And I got a good head nod there. Because there wasn't anything, you know, super exciting about it. I mean, you knew how to treat it. It's just, you just treat it. But that's full spectrum care. Is that a better experience for the member? Probably, because they didn't have to go someplace else. You know, they got treated really fast. I mean, that you want, and does that promote, you know, people staying in primary care? Yeah, because they get to practice everything they were trained to do. So you sort of want to build that. And I know we got to wrap up, so I'll stop talking.
I mean, that is a good point, and I'm not going to stop.
That gives me a chance to speak again, doesn't it? So I really appreciate all the talk about price and economics, but the core of healthcare is relationships. And caregivers and patients' relationships is what we should all be focused on, even if it's only in the back of your mind. And that primary care savings that you get isn't just this year. It gets bigger the next year and bigger the next year and bigger the next year because continuity of care reduces price, reduces cost. So we need to get back to focusing on that and not transactions, although I understand the economics of transactions.
Any closing comments then before we finish up?
The art and science of medicine. Spot on.
Okay, I think we'll finish up then. Thank you, everyone, for your comments here. Appreciate it.
So we'll take a little break until 11. So we have 15 minutes. Go talk to each other, go get some refreshments, and we'll see you back in a couple minutes. So we have for you now another panel, a smaller panel, and I'll let them introduce themselves, and then we'll have some more discussion after that. Same kind of format. So if you have questions, there'll be some Q&A stuff at the end, and then there's a microphone up there, and I'll let you go, and then we'll go from there. Thanks, guys.
Excellent. Good morning, everyone. I am super excited to be here to talk about my favorite thing, primary care. We had some good discussion in the last panel. Oh, and I guess I didn't introduce myself. Hello, I am Judy Zerzenthul. I'm the Chief Medical Officer at the Washington State Healthcare Authority and a general internist by training. And today we're going to have a panel that is talking with the City of Kirkland and Vera Whole Health about direct primary care. So I think it's a really nice extension of some of those threads that were talked about in the last 2 sessions. So maybe first I'll have both of you introduce yourself. They're going to do a little presentation about what they've been working on. I'll ask a couple of questions, and then I encourage you to come up and have some questions too. So take it away.
Good morning. My name is Julie Underwood. I'm the Deputy City Manager of Operations for the City of Kirkland. Over this past year, I stood in as interim HR director, and that's really where I got a full, I would say, education on our self-funded plan and really learned a lot more about our relationship and partnership with Vera. So I'm excited to talk about that this morning.
And I'm Carly Hammond. I'm the Vice President of Enterprise and Vera Clients. Vera Whole Health is an advanced primary care company. Primary care is also my favorite thing to talk about, so hopefully we have a lot of great information to share.
So I think you have some slides.
Yep.
Are you going to start?
Are they?
There they are.
Oh,
They're
okay.
behind us.
I was like, where are they? Okay. Thank you. All right. Okay.
Do you want to, okay. Or do you have a clicker?
I was going to say. So our journey started about 10 years ago, and naturally, like a lot of and I want to just stress this point. I feel pretty strongly about this. It's not our money. It's actually taxpayer money that we are really stewards of. And so really, and then of course we are stewards of our workforce, and we really want a healthy workforce. But so our Deputy City Manager of External Affairs, he and the previous Deputy City Manager really went on this journey to find out, and he finally calls it the Moon Project, meaning we were trying to do things differently. So we started with just examining what was working across the United States, across the country, and then try to really enhance that model. And of course, realizing for us, what could we, because we have a unionized workforce, you know, what could we do to negotiate something that was favorable for our unions? Obviously, we very, very proud of the fact that we are able to pay 100%. They wanted to keep that, but that it was a challenge, right? That was a challenge when we were seeing costs rise more than inflation. So what could we do? And so this is when we went out and looked for a model to focus on primary care, focus on prevention, to help us reduce our costs. We have seen that work. I mean, only recently have we started to see those costs increase. And I will say for a self-funded plan, you heard it this morning, those costs are driven pharmacy and kind of your outlier, you know, issues, cancer, cardiac, those kinds of things. But generally speaking, this has worked really well for us. In addition, we feel we've given our workforce choice. So we started also an HRA. So they will, and we incentivize that HRA. We incentivize it so they can earn more for that HRA if they go to Vera and they do bioscreens, again, for prevention. So generally speaking, it's been, I think, a pretty successful program. And I'm really interested in seeing how we can continue to grow and build on it. Yeah, let's see. Oh, you guys can read that, right? Okay. So I don't need to. Next, let's see, next slide. All right. Yeah, oh, the other thing. I'm a recent new Vera patient. So I originally did the PPO model, and then when I got, started, you know, for a 30-minute telemedicine visit, paying $300 out of my own pocket, I was like, oh, that's a lot, you know, and I wasn't sure what was I getting, and I liked my doctor, no problem there, but it was like, wow, that's a lot. And then I was like, well, what's this Vera thing about? So, because we have that model where you can shop, you're the consumer, you have choice, and so so I myself switched over just over a year ago to Vera. And what is so remarkable about that is really, and you heard it earlier, you know, you're moving away from kind of that transactional relationship to one of really, I think, care and concern and the whole you. I'm super, and we're going to talk about this a little bit later. I'm super excited that now we've added behavioral health. And integrating that with our primary care, I think, is going to be a game changer. Mental health is, of course, one of our biggest concerns. We have, obviously, workforces that struggle. Fire, PD, public works even. I mean, so adding behavioral health was really, I would say, one of our primary goals in this last negotiation with Vera. Like, we wanted that service. So, you know, having that relationship with your primary care, having, and now, I mean, our employees, love Vera Clinic. It's very close to our city hall, but of course there are locations all over, so our workforce live all over Puget Sound, so having that access has been incredible. And then again, having the ability to form a relationship with your primary care. We've been fortunate that we've had the same doctor serving in our clinic. So, I mean, we're talking first name basis, and you definitely feel like you've kind of gone back to that old home doctor model. And it's, again, our employees are very, very satisfied with that approach.
Yeah, so on the other side of course, balancing the equation is like, what does the data tell us? So as Julie mentioned, their employees really love it. We've had 75% of City of Kirkland employees have a visit with Vera, and 35% of their spouses and dependents. So like you heard in the previous panel, getting to activate the spouses and dependents is always a little bit of a challenge, but the employees who work for City of Kirkland certainly have adopted this, and which is a wonderful benefit. I think it's a testimony to hear from Julie herself as a patient that we believe in relationships and really building that continuity. As we talk about the value equation, one of the easiest ways to measure it is quality metrics. And we use HEDIS, which is a nationally recognized standard, and we track 9 measures, mostly around cancer screenings, depression, anxiety, and behavioral health. And you can see that in our population for Kirkland and most of our populations in the Puget Sound area, we're in the top decile, which means of all of the providers in the country who report HEDIS data, which most do, we perform in the top 10% across all 9 of those. And that really speaks to the way that we care for our members and spending time getting to know them and helping them understand the value of these preventative services. And certainly Julie has yielded out some savings as a result of keeping her workforce healthier. And then finally on the slide, I wanted to talk a little bit about access, which ended up being such a really great primer in the last panel, everyone talking about how hard it is to get primary care access. We very much pride ourselves on keeping that third next available, which means not the first, the second, but the third, in under 2 business days, usually hovering right around 1. So that means you have 3 appointments available to you within 1.5 business days for acute care needs. And we keep physicals in that 7-day week-ish time frames, which means you can have your annual visit in under 7 days. So it does take some reframing and some training of our patients, like you heard in the last panel, but resoundingly we hear things like, I really like my doctor wherever they are, Kaiser, or any of the other systems, but it's just too hard to get into them. And so we maintain and actually put our fees at risk with Julie and her team to make sure that we are maintaining access and continuity, because it is so important to make sure folks are seeing their primary care provider rather than ending up in an emergency room situation. We knew on this next slide that behavioral health was a particularly interesting and poignant topic for the group today, so we thought we would spend a moment talking about our preliminary data around behavioral health. As Julie mentioned, we hired a BHC, or behavioral health clinician, for the City of Kirkland in the 3rd quarter of last year. They helped us influence who that hire was. She has some first responder experience, which was really important to the City of Kirkland, as they have fire and police as part of their population. And while the data is fresh and certainly not to the N or the population size that I would love it to be today, since we're only 2 quarters in, but of all the members who have seen our behavioral health clinician, they also are 100% compliant on those preventative measures. So we know that when you're depressed or anxious, those types of activities become less important because you're really focused on surviving. And seeing that that population is continuing with their preventative care measures is super important. You could also see on the screen the increase in performance on their PHQ-9, which many of you know is the standard way we kind of measure anxiety and depression symptoms, most of them are seeing a significant reduction in symptoms in just a few sessions, which I think, again, is really important to the city of Kirkland as they have folks who have high intensity jobs and need to be at their prime, and having exacerbated anxiety or depression symptoms is unfortunate.
I failed to mention another workforce group that we have, and it's our RACER group, our regional crisis responders. So this is really a newer model, and it is based on obviously those in our community that are under significant mental crisis, and it's designed to give them really kind of immediate therapeutic care. And so we don't take away from our police and fire. So, but as you can imagine, they're therapists, but they also need help too. So that's another group. So having this therapist who is has that background in first response has been so critical. I mean, we were close to going out ourselves and doing a direct hire for a therapist because we felt the need was so critical for our workforce. And as you can imagine, it costs taxpayers tremendous amount of money to train and skill up firefighters and police officers. So we did not want to lose them because of burnout, so providing this type of support and care was really important to us. So we're excited to see, hopefully over time, that the workforce uses this and know it's there and know it's available.
And what we love about this model, both of us, is that it's integrated into primary care, which means our primary care providers are always screening or looking for folks with depression and anxiety symptoms and making what we call in our company a warm handoff, which means that as soon as a provider makes that identification, we're bringing in the behavioral health clinician into the room to join that appointment. So all three of them are having an immediate conversation around what next steps might be for that person. And then finally, Julie and I wanted to leave you with just a little bit around patient satisfaction. It is an incredibly important metric as well. We do find that our members are again, around the top decile of NPS, which means that they are very, very likely to recommend Vera to a friend or family member. We threw up some quotes from members, but Julie, I thought maybe you'd want to talk over maybe your own experience or others.
Yeah, and you guys primed it so well earlier this morning. We do have a very diverse workforce. We have public works staff that are very blue collar, right? They're working on busted wastewater pipes, water mains, you name it. And also, they may culturally kind of be a lot more, machismo, right? Very tough. And they are. They're really tough men and women out there. And so they're not necessarily going to understand the significance of having a primary care physician. In fact, what's been so special about having this direct connected relationship with Vera is our HR manager working with one of our staff who's in our wastewater department, very much in a lot of chronic pain and did not have a primary care. So for her to be able to call Vera and say, we've got this situation, can you help, can you, and get that individual the care they needed. And of course, I really care about the fact that our HR department looks like a department that cares about employees. Like, that is really important to us. It's like, to me, it was kind of the beautiful coming of this partnership of being able to, number one, care for our employees and also directly provide them with personal care and service. And so I just love that story because I don't know if that would have happened. I just don't know if it would have happened in any other way without the relationship we have with Vera.
Great. So I'm going to take the opportunity to ask a few questions about that. I think this is a really interesting partnership that you guys have. Julie, you mentioned at the beginning that you sort of looked around the country to figure out what was working. Can you describe for us a little bit about why you picked direct primary care as opposed to anything else? Did you consider any other kinds of models? Sort of what was that decision-making process like?
And because I wasn't at the city of Kirkland, I had to ask my colleague. I was like, what did you do? And all he said was, yes, we looked at all kinds of different models. And at the time, I mean, I remember, I think I was at another city in Washington, another great city in Washington. And our city was in a pooled model, and just thinking, what? Kirkland did what? You know, like, what do you mean they have their own clinic? I mean, it was just so like, it just was like, how, are they really? They're saving money, and they're really. It really was just like so unusual because we are so accustomed to what the system just spits out. You know, we're just so accustomed to that and just going with the flow. But to, you know, learn, and Kirkland did quite the road show, if you can imagine, over 10 years ago. It was really unique and really unusual, and at that time, the workforce would have been probably more like 500, I mean, we're 850 now, it might have been like 600, I mean, so we've really, our workforce has increased over time. We had a huge annexation. But the point there is we, I think, just really wanted to be more in the driver's seat, be much more in the, and in fact, we, I also think this is really unique. We meet monthly with Vera. We review our statistics. How are we doing? Are we seeing trends? Are we seeing, you know, and so again, to feel like we were more in control of controlling those costs, controlling the services our employees get to see was, I think, kind of probably the biggest driver.
Great. I think this next question is for both of you. 10 years is a long time to have a partnership, especially how rapidly some of this has been changing. What are the big things that have changed over that time? Have bits of the model changed, or services? Do you want to talk a little bit about that?
Yeah, sure. The model has certainly evolved over the last 10 years, as you can imagine. The city of Kirkland was one of our first clients, and they've been a great partner in evolving alongside with us. So our model about 10 years ago always has been oriented around the care team with the provider, and then an MA and on-site labs and a dispensary. But as the populations have changed, and as we know what folks are not getting in the community, we've added in other services like diabetes education and nutrition as part of our core model. We've also, as you've heard, now we consider behavioral health integrated in the primary care setting to be a part of the core model. So the way we believe that folks need to get services and really stay within the four walls, sometimes virtual four walls, but the four walls of primary care has evolved to the point where we really want folks to believe that that's their home and the place where they should get care. So our model has certainly evolved to meet the demands of this growing kind of healthcare crisis, and folks, especially post-COVID, avoiding necessary care because it's just too cumbersome, and bringing that all into the primary care model. Our relationship with City of Kirkland has sort of followed that trail, as well as certainly with them adopting behavioral health in the last year, which we believe is to be a really important component of our model.
Yes.
Yeah.
Excellent. So the next question, you each have a piece of it, and I think it was hinted at a little in the last panel around engagement. So primary care is a rough space right now, especially for clinicians that are there. Are the Vera clinicians, how do you engage them? Do they stay over time, have job satisfaction, that kinds of things? And then for the City of Kirkland, how do you engage patients in this model? You mentioned you only recently moved in. you know, sort of, is it easy or hard to get people to seek out Vera versus other kinds of models, and what does that look like for the employees?
Yeah, provider satisfaction is certainly an area that we focus on from an employee perspective. I've worked at Vera for 6 years, so I've seen sort of the evolution of that. We do have like longevity in our partnerships. Julie mentioned their provider, as they like to view it, Dr. Baker. It certainly has been a longstanding employee of ours, and she's a really wonderful provider. I think what attracts providers to Vera specifically is the way that we orient our clinical model, where we have longer visits with patients. That's really what primary care providers want to hear. You heard yourself and a couple of the older school doctors talk about the way that they provided medicine, which was this longitudinal relationship with someone where they were not seeking specialties. You know, we really try to keep our referral pattern to about below 10%, which means that 90% of a person's primary care services are happening in the primary care clinic, which is what providers want. Our visit times are a little bit longer. Our providers see our patients for acute visits between 20 and 30 minutes and well visits between 40 and 60, which really makes a longer conversation where we're not, my primary care provider used to give me a piece of paper with 1 period, 2 period, and I got to write 2 things down, and those were the 2 things that we talked about. That's not really the experience that we have at Vera, where we really are trying to address all of your needs in one visit. And we do see our providers, they are greatly satisfied. They're seeing between 10 and 14 patients per day, which the practices I used to manage, including the 1.1 and 1.2 clinic, we're seeing 25 to 30. So they enjoy seeing fewer patients per day. But the one thing I'll say on the flip side of that model that can sometimes be a challenge for our providers is that they're responsible for a lot more depth with a person. Which means that the out of visit work is bigger. I don't think they find it to be such a challenge that they don't want to work for us, but there isn't that same passing off to other providers that you see in more community-oriented practices. So the between visit care is a lot for our providers, which is why we have longer visit times. They see less patients. Their panel sizes are smaller than community providers because we really do expect them to go deep.
That's personally been my experience as a patient there, and you know, Dr. Baker she attends the monthly meetings, and again, I think because she I think really projects that she cares about our employees. It just I think it's also a great way to really invite that employee or that patient, that client to return. So, I mean, there definitely, I think, have been experiences in my past where I just did feel like I was a number and a cog, and I could have been anybody. And so I think having that personal care has really been important. We just entered into another 5-year agreement with Vera. So again, we're very, very pleased, very, very happy with what services. We're also, do feel like they are doing, I think, a pretty admirable job at also trying to control and maintain costs. So that was a big piece because, again, this is the increasing costs is really having us start to look at, are we finally at the place in time where we have to share more of those costs? We do have to start probably evaluating that, though not quite ready, but I do think that is a question we have to ask ourselves. But I definitely think Vera is still going to be part of the equation, that direct care.
Judy, you asked about patient engagement, and that is one of the, I would say, services or tasks that we typically take on for our clients. And engagement is multifactorial. Certainly, we're learning a lot more about what I would say consumer engagement or going directly to people. So we spend a lot of time on an annual basis thinking about how to engage and re-engage folks. We don't find the re-engagement to be too hard, but to help folks understand about Vera, we do a few home mailers per year talking about services. We also typically send out, with employers' blessing or with our clients' blessing, emails reminding folks about preventative care services that they may be due for. And then we certainly like to host on-site events on behalf of our clients, or even open houses where folks can come to our clinics and learn a little bit about us and meet Lisa or some of our other providers. So we view patient engagement or employee engagement as a really core responsibility of ours, and we look to partner with our clients to drive messaging in whatever way makes sense for them.
And it really helps that they come on site and do the bioscreenings.
Yeah, that's right.
So in fact, we have 2 this spring. We'll probably have some in the fall. The mammogram mobile, flu shots. I mean, all of those touches, I think, again, we really appreciate, our workforce really appreciates the convenience of that.
Yeah, because I if you can't hear, like, love primary care, like, believe in it so much, but it's not exactly a service that everybody wants. You know, if you're in the consumer product goods space, you know, like, someone does want those products, and primary care is a hard one to sell. So we use touch points like mammos and flu shots and biometric screenings as entree points where folks may feel that barrier or that kind of anxiety around engaging care a little bit more palatable. So we try to meet folks where they are and use those as opportunities to sort of shepherd them or move them along that continuum so they're ready for primary care.
Great. So I have one more question, and then I'm going to invite you guys to come on up and ask any questions. So this is all very impressive. It sounds like a really cool partnership. Are there any downsides or places where more work is needed?
You know, I think it's probably, to me, it's what does, because we've got, obviously you all do too, the Gen Zs entering the workforce and really kind of better understanding what type of care are they looking for. I'm assuming they're going to look for more telemedicine, and so we've recently started pushing out the mobile option there, and I think that's really helpful. But it's like, that's just to Vera. Are there other services that they're going to be interested in? So I'd be very much interested in partnering with Vera and our other providers and understanding the needs of that younger workforce. And then I think just continuing to, I think, control costs, but also provide value and care. So.
I would certainly echo that the multi-generational employer setting is really interesting. I think we, for the first time in kind of our history, we have so many different age groups actively working, and to find a care model that meets anyone from an alpha, you know, an older, has certainly been a challenge for us. And we are doing more and investigating more and investing more in this sort of digital or I'll call it self-service kind of space where you are the director of your own care versus, you know, speaking with a person first. We're doing a lot more technology first, which is interesting and is an evolution of the Vera model. The other place where I think we've had some challenges, and we're certainly on the other side of them, is Vera has experienced some really nice growth, and from my chair, that's really exciting. That means more folks are engaging in Vera, and we are becoming a more used resource in the Seattle area, but it's not without its pinches. And I would certainly say we're on the other side of that, but staffing up and continuing to find really good staff has been a challenge for us.
Yeah,
and
it took you a long time.
Took us a long time
to find the behavioral. I mean, like, I want to say 9
months.
10 months.
And that's partially because we were looking for someone with really specific skill sets around first responders, and but also healthcare is a hard economy to recruit in, and finding, I think the most acute role for me is medical assistants. There's plenty of competition here, and finding really good staff has been a challenge. And we do feel that pinch, and we're always looking for better ways to recruit and retain our staff, because it is so important to our clients, like the City of Kirkland, that they know their MAs, they know their doctors, and it's important to us too. And so finding and retaining staff continues to be a challenge.
So, anyone? More questions for, yeah? Come on up to the mic. Yes. You should.
Glad to hear that you're doing long appointment times.
Yeah,
We find that that builds trust.
absolutely.
Relationships that we were talking about. The question is more of finance. So I think you're an advanced PCP model.
That's right.
How are you finding employers ready to have a value-based care discussion? And from your side, how was value-based care and that model part of your evaluation, especially as you're looking to reduce costs downstream? Was it a critical part? And I'd just love to hear your opinion.
Yeah, so the questions around like value-based care and sort of alternative payment models, I love that question because I have clients and my background is totally an alternative payment model. So I have clients on the cap table, that's not the city of Kirkland, but then we also have clients who are on sort of a fixed per member per month flat fee. So we have the range of spectrums and it really is sort of a ongoing evolution for clients who are ready to take risk and how much. We're finding more and more folks are on this kind of, we call it like a glide path, where they're interested in taking some or having us put some fees at risk or put some guarantees. And we don't find that value-based care conversation to be too difficult. Now we have some employers out there who are really pushing us to take advanced risk and be on sort of a capitated model, which is really interesting. But we're finding that more and more employers are interested in value-based care arrangements, and that's becoming more of an expectation. And so it's not hard for us since we have a pretty deep bench of all the way from fixed PUPM all the way to this full capitation model I talk about. But the city of Kirkland has had us put some fees at risk, which puts us in a true value-based care arrangement. And we're seeing more and more employers expect that of us.
Yeah, I mean, I guess I'm kind of like, well, that's like apple pie. Who doesn't want that? Like, I would think everyone. I think also we were definitely hearing from our workforce about the access, and we talked about it earlier. I mean, usually when someone is ready to call, I'm just using myself as an example, when I'm ready to call a doctor, I want to see them right then. I don't have to wait, you know, and so that was a big piece of it too. So I think being able to, in fact, it's in our, you know, contract that we will have and they've been great about meeting that. So I think that is a big piece of it. But yeah, I guess it wasn't really a hard sell. Yeah.
Oh.
I thought you were going to ask us a question.
Yes, I was like, oh, another question. No. So maybe I'll ask another question. So can you talk a little bit, you mentioned, Julie, that you've got a range of workforces, including blue-collar folks. How does Vera and the city of Kirkland get those referrals for health-related social needs that might come up in a clinical visit but aren't contained within that suite? Sort of how do they connect people to the community to serve some of those needs? And also how do they connect outside the system, thinking about specialists, maybe more advanced behavioral health care, and then connect back to the primary care?
You know, I saw that question. You sent it, and I was like, I don't really know how to answer that question. I really don't. In other words, I guess I'm like, when you mean social, maybe you can help me.
I can take a
Or yeah, I was like,
it's more of a Vera question, I think, so you're good.
So over the last couple of years of social determinants of health becomes more of a hot button topic, and we know that people aren't at their best if their social needs aren't and their physical needs aren't met. We've started performing a basic SDOH assessment. And then as folks screen positive, we are aligning their needs to what they've told us. Our providers, I'm like trying not to use too many jargon terms, but I do like this one. Our providers are benefits driven or benefits aware. So we know of what benefits are available to our patients, including certain community or social programs or other types of programs, and we use those as referral mechanisms. For folks who have SDOH or high needs, we do see that our behavioral health clinician, whether they're impaneled to her from a therapy perspective, she is following up on those types of needs and ensuring that community needs are met and we're closing the loop. So we have a lot of we're aware of a lot of local resources in the Puget Sound, more specifically in the Kirkland area, and we use those as referral mechanisms and ensure that our folks are getting the right care.
Great. Any last words?
No, it's such a joy and a pleasure to be here and talk about, primary care and how important that relationship is for folks and how much it can drive both health outcomes but also financial outcomes for clients.
Yeah, and I'm just excited to partner with Vera and, finding newer, more innovative ways to serve our workforce.
Excellent. Well, I'd like to have all of you join me in thanking our panelists, and it's great to hear a case study, so thank you.
Thank you all so much. Now I get to talk a little bit more. I think that's how this is going to work, and I don't know how to. Denise can get me my slides so I know what I'm supposed to talk about, but that was these guys. I'm going to talk about the Alliance a little bit and the community checkup that we just put out, and thank everybody for coming and supporting us. Next slide, please. And I'll tell these guys I might have some things to build, but on the left side, you'll just see our history. So actually, we were incorporated in 2004. The first official meeting was like July of 2005. It was at the King County Library. I remember attending. I don't know if anyone else in the room remembers attending, but Michelle is there. The two of us. It was great. And we're still here, so I don't know what that means, Michelle, but and it started as the Puget Sound Health Alliance. And it was started by Ron Sims, who was the county executive at the time. He said, my costs are going up, quality's not great. I own a hospital, by the way, called Harborview, and they're charging me $1,100 for an MRI, and I did the math. And the MRIs actually only cost $18, because that's what the staff costs and the variable costs are. Today, it might be $100. If you want to amortize it, it's about $200, right? And so he was sort of mad about that, and he wanted to bring everybody together. So what his concept was, I don't want to just bring purchasers together. I need everybody at the table so we can start solving some of the challenges and the problems that we have. One of the challenges we had was we had no data. There wasn't transparency stuff. We didn't have any of that stuff. And we had to convince people to provide data, that we would be good stewards of that data. As you can imagine, some of us, I was working for a health plan at the time, wasn't real excited about that. Oh my God, you're gonna see all of our stuff, including our prices, and how can you do that? And we worked through that. So we worked through being able to get providers together, the health economists together, the actuaries, the plans, everyone to agree, okay, we can take this data, it'll be blinded, it'll be scrubbed, and now you can produce some report. And so we produced the first community checkup report back in 2008. We evolved it over time. We created the Washington Common Measure Set, wherever Judy went. And we're able to continue to push out this report. We just did our 19th report that went out last week. If you haven't looked, you might want to. It's kind of fun if you're really nerdy and into numbers. If you're not really nerdy and into numbers, read the report that Nick wrote, because it's much easier to read. Thank you, Nick. In 2011, we did a consumer site, and we actually had a couple of customers use it to help educate sort of the health literacy issues that kind of came up. What's an insurance plan? What's a co-insurance? I don't understand what that means. That type of work. And then a little over a decade ago, we actually spread out to the entire state. And so that allowed us to really look across the mountains, not be just limited to the Puget Sound region, and start dealing with some of the issues of rural Washington and the issues related to healthcare in more isolated areas. And then at the end, you just see us, we put a little 20th anniversary, button on there. But really, we've remained true to the fact that we believe that, and you heard it, I think, this morning from Dr. Bai and Boeing, that purchasers have a fair amount of power they need to exercise. I think we just heard it with City of Kirkland, that they have power they need to exercise, and when they do so, they get sort of what you want. And so we are a purchaser-led, purchaser-aligned organization, but we also believe that, and we talked about this earlier, that you have to manage your expenses closely, that you have to be, prescriptive about it. You have to expect certain results. And I think that's what you've heard from a couple of the employers here today, is that, they have certain expectations. Boeing has, I want to be flat. I don't want my trend to go up year over year, and they've been able to do that. You want a certain member experience, et cetera. But we also believe that to be successful, we have to do that as a multi-stakeholder coalition, that doing that is the way we can be successful. If you go to the next slide, this is what I was talking about before in words, right? So here's, the nice equation, and your definition of access, your definition of appropriateness is fine, whatever that might be. I think if you're a provider, you may have different definitions all the way down this line. But that, I think, will, helps kind of frame kind of where we were going in terms of how do you keep the things in balance, right? And even when I was with one of the health plans, we looked at a very expensive specialty group, and they said, oh, they're very expensive. And I said, well, the professional fees are expensive, but their total cost is cheap. They went, well, but they're expensive. I said, no, they're not expensive. They have low complication rates. They have great outcomes. They use ASCs. The professional fees are higher than everybody else, but their overall cost is lower. And, oh, by the way, they're willing to take a risk-based, value-based contract, and they'll do bundled payments. So they actually will save you money, and I think they saved us $15 million the first year. And they got paid more. So quality better. Cost was actually lower, but to the provider was better. It's just how do you shift the costs around in the ways you need to do that. Let me get into the community checkup a little bit. So a bunch of colors on the wall. These represent, on the right-hand side, are the different HEDIS measures at the state level. And because the individual providers say, well, my scores are better than that. Or the plan might say, my scores are better than that. But at the state level, this is what we're seeing. You want green. Green is better. Shocking, right? I know. Salmon, even though we're in Seattle, is not so good. And the majority of our measures are below the 20th percentile, 25th percentile. Why is that? Couple things. We have a lot of people that don't access care. If you look at the more deprived neighborhoods, and that's in our community checkup, 20% of people get no care at all. If you're in a more privileged neighborhood, it's down to 6%. So there's a difference there. Now, is that rural settings? Is it urban settings? The answer is yes on both. And then there's another percentage of people that are getting care, but they're not getting care they're not attributing to a primary care doc. And we were talking a lot about that. And when you don't, you get some care, but you don't get comprehensive care. And when that happens, you also get poorer quality scores. And so we have about 30% of the population, both on commercial and on Medicaid, that does not appear to have a usual source of care, which would help drive some of the quality initiatives. On the right-hand side, this is because Lloyd in the back asked a couple of years ago, wow, what's been going year over year? Is it just a blip? And the answer is it's not really a blip. It's actually been fairly consistent year over year. So we have a ways to go to improve the overall health of the community. However, you know, there are individual groups that do a fantastic job. If you go to the next slide, I'll show you a couple of them. You won't be able to read the screen because the things are small. On the right is commercial, on the left is Medicaid. The little circles are around the best clinics in the state. And if you took the top line, that's just breast cancer screening just for fun. You know, statewide, on the commercial side, 66% of women are getting screened appropriately. Is that good? Some people are nodding their head, yes, okay. I would say no as a clinician, because I would think it should be a little bit higher. The 90th percentile nationally is 80%. But there's a practice that's at 92%. So you can actually get well above the 90th percentile. Same thing is true on the Medicaid side. There's a practice in Grandview, 83% of their patients are getting screened. So it can be done. They probably have systems in place to do that, to make sure they're pulling people in, not waiting for them to show up. And you can see it all along the way. The diabetic eye exam one's pretty easy because you just screen people when they walk in. You don't wait and try to refer them to someplace. You just have a retinal scanner right there, and you just screen them, and now you're done. So there's things you can do, and the retinal scanners are not expensive. We tried to get one in my practice back 25 years ago, and my hospital didn't want to pay for it because they said it's $3,000. I said, it'll generate a lot of money, and they went, oh, it's $3,000. I'm going like, God. So I hit my head a few times and didn't go very much farther. So there are some great practices. And then there's a way to measure medical groups. And our quality improvement team has done this in a couple of different ways. On the upper right is the quality measures. These are how you rank within the state as a medical group. And they shift around a little bit. If you actually look at the actual numbers, they're all pretty close, at least in that top 5. And you can see both commercial and Medicare. Now, some of you might say, I only care about cost. And that's the bottom left. And that's the ones in terms of, how do you look from a cost standpoint? And I thought it was interesting because I used to work at a community health center, that community health centers popped up really high on the commercial cost standpoint because we spent a lot of time, taking care of that person and not ever referring them because we never could. But I thought that was kind of fascinating. Now, some of you might say, well, wait, I want a balance in there because I don't want all one and want all the other. So you go to the community checkup, you can actually toggle through and slide what % you want quality and what % you want cost. So if you want 90% quality, 10% quality, you can actually choose that, and the whole list will change for you. And so you can say, oh, that's how it is. And you can look at it by medical group or by clinic, so it's kind of fun. And then the next piece is just my anticipation of what I thought we were going to talk about today. So I think I might have got some of these. Healthcare is complex, right? I think we got that. I think we heard from Greg that there's a skill set that you need to be able to manage this, and a lot of the HR teams don't have that skill set, and it's hard for them, and it's not their area of expertise, and they need to rely on others, and I think that's all very true. However, what I've heard from a couple too many purchasers is that, well, once a year I look at my benefit plan and my plan design, and that's all I do. And my comment was, you got to be looking at it all the time because things change over time, and you need to be up on it just like you would be, your checking account and your bank account. You don't just look at it once a year. You look at it constantly because things can change, or you may learn something and say, oh, I got to go look at that and see do I have to adjust something one way or the other. We've heard a lot of times that people don't like to change, especially if you're an HR person, because if I choose the wrong plan design, someone's going to get mad at me. Usually it's the CEO or the CEO's husband or something like that. I mean, I don't know. And if I keep things the same, no, I don't get fired, right? So that's another inertia problem that we have. But inertia is tough because, you know, doing something different is, well, it's different. And, you know, if you don't do anything, it's pretty easy. You just keep doing the same stuff. But you have to make choices. And I think we heard that on both panels, that you make choices that are in the best interest of that population that you're serving. And when you do so, it will help. It also helps when you hear other people doing similar choices. So if you hear that there's you know, another group that tried X, Y, and Z, and it worked in this case and not that case, you can say, does that apply to my population? Because it might not. But if it does, you go, oh, someone else has done this, and then you can just talk to them and say, you know, why did that happen the way you did? I would say, you know, there are tough challenges to do, and on the I think one is we got to make sure everyone has a source of care. I think we heard that a lot. There's clear quality benefits. There's clear cost benefits of that. But sometimes, why is that a tough choice, right? Why should that be a tough choice? Because you might actually say, I'm going to require Paul to have a primary care doc. I'm going to require it in my plan. Now, Paul's going to say, I don't want one. You might say, I don't care. I'm going to give you one. Now, he's going to start complaining. You know, is that going to be a problem for me? Maybe not, because I think it's in his best interest to have somebody, right? So you may have to deal with, you know, what does that look like? That could be tough. What about driving people to the best quality? Does anyone want to go to the average doc? How about the below average doc? You don't? How many people have a straight PPO plan? You're all raising, all you have to raise your hands because I think that's what you have. So if you have a full spectrum, you know, everybody in the market's in, you've got good and you've got less good. And so how are you deciding where to go with that? And I think you have to help people make those choices. Now, that's easier said than done. That's why it's a tough challenge. And then I think if you're the employer, you really have to look at your vendors and your business partners, and whether it's a broker or a consultant, whoever, and really have high expectations for them. I think you have to be really clear, and you have to have that performance demarcated for you so that you can tell that they're doing a good job. And you want full transparency and everything else that goes along with that. And I think that's all I had to talk about. And I'm trying to end a little bit early so we can have lunch. So there are box lunches out in the foyer. I don't know what's in the box lunches. Don't ask me. They should be labeled. They're clearly labeled. I think maybe there might be some dairy-free ones. There could be, is there a gluten-free one? We don't know. There could be. Just thinking about all you celiacs, there's 100 people, so at least one of you has to be a celiac. Unless you're Italian, then it's like 1 out of 8. You know, I'm just going from there. So I encourage you to do that. I encourage you to keep talking. We're going to get back together about 10 to 1 or so, and you know, come back to the room if you need to make phone calls or whatever. Appreciate you all being here. And this afternoon we've got a real focus on the purchaser side of things. So I think you'll hear from Cora about what they did in New York, making some tough choices and the benefits to their employees that they got. We'll get a little more panel with some of our couple of our board members are on that panel, so that's great. And then we're going to finish with Sean, who is now amending all of his slides again because of whatever happened this morning in D.C. But he comes from the D.C. area and can give us sort of a national perspective from, you know, what purchasers are thinking and how we're going to move forward.
So I'm really pleased to introduce Cora Upsall to all of you. Truly amazing person. So happy to have met her and to be able to call her a friend. And so Cora is the Health Fund Director for 32BJ. She was appointed director back in 2021. Her focus has been, well, to reduce cost for her members, right? She puts the union members at the center of all the decisions that are made, and really working to reduce trend and make things affordable. And it's all through a data-driven approach. And she's going to share so much with you that I'm going to let her just hop right in here.
Oh, you're so nice. Thank you. Perfect. All right, good afternoon. So I have the distinct pleasure of doing the afternoon session, which means I need to keep you all awake. So as Denise said, my name is Cora Upsall. I'm the director of the 32BJ Health Fund. And before I get into things, I want to actually get everybody to stand up. We're going to just do a little shimmy and wake ourselves up. Shake your arms, shake your legs. All right, now I want you all to make sure you know who's sitting next to you. I heard when I was at lunch that everyone knows everyone, but look around. This is going to matter at the end. Okay, so just make sure you see the people sitting behind you. Make sure you know their names. All right. All right, we can all sit down. Thank you. I like to get the blood flowing, right? After we've all had our delicious lunches, and now you got to go listen to someone you don't know talk. So as Denise said, my name is Cora Upsall. I'm the director of the 32BJ Health Fund. And today, Denise and I came up with this title, so it sounds really fancy. The Path to Possibility, How to Enact Change in Your Benefits. Okay, that's like a lot of words to say. Next slide, please. I'm really going to talk about three things. Three questions. We're going to talk about three questions today. One, why is change necessary? And I think from everything I've heard this morning, everyone in this room understands it. We're just going to do a refresher from Cora's perspective. Two, how do we drive change? What are practical solutions that everyone in this room can do to actually make change happen? And then three, what does it take to make the change happen? So that is what we're going to do today, right? We're going to cover these three questions, and I like to just level set. It's an agenda, but at least you kind of know where my talk goes from here. But first, let me tell you a little bit about who I am. And again, I've got a lot of slides that are my memory. It's like my, cheat sheet. I think you'll probably get copies of the slides, I'm guessing. So you can ignore what's up there and I'll just listen to me. 32BJ Health Fund, it's a Taft-Hartley benefit fund based out of New York City. We have over 200,000 covered lives for the 32BJ SEIU union. So I am the Taft-Hartley benefit fund, which means I am not the union. And I always clarify that because someone always says, do you know so-and-so? No, I don't, but I probably provide their benefits. The 32BJ union is a multi-employer plan. It's got 5,000 employers that contribute to the plan. The union itself, the membership, is made up of the largest property service union in the country. And so these are your commercial and residential real estate workers. They are if you ever come to New York City, these are your maintenance workers, your window washers, your property management folks, your supers, your door people. But it's a growing union, so it also includes school workers. And most recently, if you fly into any of the New York, New Jersey airports, it's the airport workers, the folks cleaning the plane and pushing wheelchairs. And so it's a growing union. And one of the things about us as the health fund is that we have no premium sharing. It's 100% paid for by the employers. We have no in-network deductible, and we have low copays. We generally like to say, if the members do what we tell them to, we want them to pay as little as possible for health care, which is a really high bar. Which is also why I would say we've got three guiding principles here at the Health Fund. One, the very first one, and they're in order for a reason, is that we want to aim to keep our trend at 50% of the national average. And I will tell you, over the last 5 years, we are running flat. And we do that through the change that we'll talk about later. 2, we keep the members at the center of everything we do, because as a union membership, if we don't have members, I don't have a job. But I always put money first, because if we can't provide sustainable benefits, then our members are going to have to start paying for premiums, which is a strike issue, and I'm not getting in the middle of that mess. And then the third guiding principle we have is it is the responsibility of the health fund to solve the affordability crisis, not on the backs of our members, which means we need to come up with creative solutions that save us money and still make a really high quality and affordable benefit for my members. So I say all of that to say, let's get into it. So first, why is change necessary? These are my stats. And I start here because I want to level set. I've got 200,000 lives, which is a lot. And I'm going to talk in big numbers. But my experience is not that different than somebody who's got, 200 members or 2,000 members or 20,000 members. But I will say in 2023, we spent $1.4 billion in healthcare. $1.4 billion. Of that, 55% of what we spent on healthcare was on inpatient and outpatient hospitals. 55%. So we'll hear a lot, we talk a lot, it's the insurance companies, it's pharma, it's pharmacy. I'm going to challenge you and say, yes, and for us, it's hospitals. New York City is an extremely expensive place. It's hospitals. Healthcare, I totally duplicated this slide on the next slide, so we'll go to the next one because it's prettier. Well, I guess it's not prettier, but it was prettier in my head. These are my notes. So from 2014 to 2013, these are my fun facts that I like to use because it talks about why change is necessary. From 2014 to 2023, wages increased 54%, healthcare costs went up 230%. When you look at healthcare as a percentage of total compensation, it went from 17% to 37%. And we know that had healthcare gone up at just the rate of inflation, members would have had $5,000 more in their pockets than they do today, a year. And so I put these numbers out here because I think they're so important to show that, one of the things that I love about unions is they understand total compensation. Union members understand total compensation better than anyone I've ever met. And it's that healthcare is eating up wages and other benefits. So much so that I can even put it and say that in 2023, we spent $372 million on hospital cares for the 5 largest academic medical centers in New York City, which was more than the employers paid for pension in the entire benefit fund. 5 hospitals cost us more than pension does. So this is why I would say, why is change necessary? Because it's really expensive. So if we move on, I just want to say, okay, we all know it's expensive, so I wanted to level set. Let's talk a little bit about what can we do. So now this is the practical part. And I really have it broken down into 5 things that you can do. We're going to talk about data. We're going to talk about programs you can do that I did and that everybody can do. It's not New York specific. It's not always, by the way, 200,000 lives specific. Sometimes I actually think smaller people have a better ability to enact change than big guys like me. We're going to talk about some tools you can use. I'm going to challenge you all to go to RFP. And then I'm going to talk about the thing that I love, which is policy. And so we're going to cover these things in the next, 15-ish minutes. All right, so next slide. First, data. Data drives change. I mentioned this at the beginning that we spent 55% on inpatient and outpatient hospitals, but the national average, according to CMS in 2019, was 44%. And I know this because I get my claims data. I know that we're all supposed to be getting our claims data. Is everyone in this room getting their claims data? I like that I'm getting most nods. Because look, getting your claims data is not going to create change. But you can't fix what you can't see, and you can't make programs that you don't know where to spend your money, right? You got to know where your money is being spent. And so when I look at this and I say, okay, if 44%, because I think 55% is bad, but 44% is bad, that means maybe we should be talking about hospital prices. Next slide. Got to catch up over here. So I talk about you can't fix what you can't see. How many people have a data analyst on staff? Probably maybe a quarter of folks. How many people think they can't afford to have a data analyst on staff? Oh, there's a smaller number. That means there's a wide gap between those of you who need to hire a data analyst. I will tell you, hire a data analyst. If you do nothing else, hire a data analyst. Your data analyst, anyone you hire, should be able to find their salary's worth of savings in the first year. And if they can't, you have the wrong data analyst, you don't have a better health plan. You laugh, I'm serious. I mean, I think I think anyone should be able to find savings in your health plan. And because I think, and I take this because I want to tell you what a data analyst can do for you. Those of you who have it, I hope you go, oh no, Corey, you're absolutely right. They can create visuals. I heard Drew say it, healthcare is complicated. Distilling complex healthcare messages into something that is easy for you to digest and your managers to digest and the CFO and the CEO to digest takes a lot of brain space, and a really solid analyst can help you do that. Can help you make the case for what you need to do next. They can take it and say, all right, you say, I want to look at this copay. Hey, or this vendor comes in and says they can save you hundreds of thousands of dollars. I'll be a minute. We're a skeptical bunch here at 32BJ. I would say I have a distrust and verify mentality. And I have analysts that validate every single assumption that is being sent to us by vendors. It's also why I don't have a lot of point solutions, because it turns out I don't really believe they're savings estimates. But a good data analyst is going to be able to help you have the information with the claims data you have to say whether or not there's an opportunity for you there. It helps you proactively engage with your leadership. If they come and say, hey, I heard this, I read this thing in the paper, because I get those. Do you all get those questions where I read this thing in the paper, what does that mean for us? I get those. Like, there was the story about, what are you doing about opioids? Because of the story from the New York Times not too long ago. It's like, well, that story was about a story from a few years ago, but cool. You can't do that without a data analyst. And lastly, it really helps you be thoughtful in your benefit decision. Sometimes it's really easy to be emotional in our benefit decisions. We want our members to be healthy and happy. We want them to have access to high quality care. Those are often emotional perspectives. Having a good, solid data and an analyst will help you look at it in a practical way that will make the cases easier for you to do. All right, so data drives change. What's the next step? I would say create win-win programs. In the last 5 years, I've saved over $200 million for my health fund. $200 million. When I spend about $2 billion a year, $200 million is a lot of money. And I will say this has started because about 20 years ago, the health fund was costing more than they were getting in premiums. And the employers and the union looked at each other and said, maybe instead of fighting about this at the bargaining table, we should fight against increasing healthcare costs. And so I only want to just say that it has taken us 20 years to get here. This is not something you can do overnight. And I will say I want everyone in this room should be able to come up with one thing. It's incremental at times. And so I look at it as I have two different types of solutions. We've got utilization solutions and price solutions. Sometimes they overlap. Next slide. So let's talk about them. So we've got utilization solutions. And these are solutions that have improved member accountability. They have helped our members are really satisfied with it, and they're getting better care. We have no premium sharing is one of them I consider a utilization solution. We have no in-network deductibles. We have Centers of Excellence program. Karam's in the back. We have Lantern, which is another program, which is driving savings sends members to high quality care, I will tell you, make them mandatory. If you want the savings, make them mandatory. We have mandatory centers of excellence for joint, bariatric, and we just added spine this year. These are programs that folks like Karam will help you figure out how to roll out to your membership, and they will get high quality care and will cost you thousands and thousands of dollars less per surgery. Highly recommend it. We have a high value maternity program where moms can have a baby for no copay. None. Or maybe $40, which is your first prenatal copay. But otherwise, I just saw a mom here who just dropped her jaw. You can have a baby for one $40 copay. Plus, we give our members a gift if they're in this program. And we did this by doing our own RFI using quality, national quality metrics. And we have 8 hospitals that our moms can go have babies at, and they get a gift, and they're going to have better outcomes. And I will tell you firsthand, we have lowered the episiotomy rate in New York City for all New Yorkers strictly by our program alone. And by the way, I think I saved costs in the process. All right, so that's your utilization programs. We also know we need price solutions, right? And so one of the ways we've done price solutions is that first we started with our data, and we looked at it and we saw that there's a wide price gap depending on where you go to have your care. If you look at the graph, it kind of shows you that a colonoscopy, and this is from 2021, you could have a colonoscopy for $2,000, or you can have a colonoscopy for almost $11,000. Why is having a colonoscopy cost 5 times as much for literally going across a park? We don't know. But by knowing that, we were able to communicate to our members the need for some of these price solutions. So one of the first things we did also, we've now, on the pharmacy side, we joined a group purchasing coalition. I would recommend them to anyone. You get to keep your autonomy, but you get to leverage the 3 million plus lives they have. It's Health Trust. I think they're amazing. I'll talk to anyone who wants to talk about them. Because, and it came up earlier this morning, more people is more power. I don't always think it works necessarily on the medical side, but it definitely works on the pharmacy side. And the right group purchasing coalition will allow you to maintain your autonomy as an employer. We have done the price compare, and then we've done network management. And I'm pretty sure my next slide talks about network management. It does, all right. We've done network management. We tiered our network in 2019, and we did it based on price. And we did it not in a vacuum. We did it through massive amounts of communication to our members. If you recall, I said at the beginning, I said, you know, union members are one of the few groups of people who really, truly understand total compensation. And so the union went to their membership and they said, I think there's probably a politer way of saying this, but you know, we're being screwed, and we want to give more money to your pocketbooks, and so we're going to tier the network. And we're going to say, in New York City, we're really fortunate. I got 5 academic medical centers, plus a city hospital system, plus a safety net system. So essentially 7 hospital systems in New York City. And we said, look, we're going to tier this based on price alone, because they're all good, they're all high quality. The most expensive hospitals are going to be non-preferred. You can still go there, but you have to pay $1,000 for inpatient or $250 copay for outpatient. Or, come on over here, members, you can go to these really high quality preferred hospitals for a $100 copay for inpatient and a $75 copay for outpatient. And it worked. But I will tell you, it worked because of communication. If we had done it in a vacuum and they just showed up one day and we told them in December they were going to have a new copay structure, it never would have worked. It worked because we had buy-in from the membership. So I said win-win. This is where the win-win starts to come into play. I will say, we talked about how healthcare is hard. We talked about power. This was the union's first taste, or the health fund's first taste at where our power didn't match the power of the hospitals. In New York City, in New York State, the greatest lobbying organization is the Greater New York Hospital Association. Most powerful lobbying organization in the state. And turns out when we tried to tier our networks, we had a hospital system, New York Presbyterian, that said, cool, I understand we're the most expensive hospital system in the city, but I have a contract with Anthem that says I get to be preferred. I'm sorry, what? And so one of the ways we were able to engage the membership is we said, hey members, this hospital is dictating what your benefits look like. What do you think? Turns out, not good. And so we won that fight. But then in 2021, New York Presbyterian came back and said, I know we allowed you to make some of our hospitals non-preferred, but we have a clause with Anthem that says we absolutely get to be preferred, and if you have any steerage programs or utilization programs, such as our maternity program, we must be included in this as well. Unions don't do great being told by an external party that they don't get to do what they want to do. I like that I've got my SEIU folks over here laughing, because you know what I'm talking about. So New York Presbyterian said, hey, cool, we're gonna make us be preferred again. We politely declined, and through a very large, comprehensive, and coordinated campaign, public campaign, because we say the quiet part out loud, we fought back and removed New York Presbyterian from our network on 1/1/2022. We did it with 17 continuation of care cases and almost no member noise. And we did that because we engaged the members. But you can't do that in a vacuum, right? You can't just take something away. What we were able to do is then take that savings, and in the largest contract negotiation that happened for the union and the employers, is they took the $35 million that we estimated savings by just removing this hospital system and moving members to a lower cost of care. They were able to give the members the largest wage increase in contract history, a bonus, because these are the folks who were in the midst of COVID, and increase their pension, and for the employers who 100% pay for the insurance, gave them a 2-month holiday in 2022, netting to a 0% increase, and then holding them to less than a 3% increase over the next 4 years. How many of you in this room have less than a 3% premium increase over the last 4 years? So when we talk about tough choices, you gotta create the win-win. We can't just do this to then say, oh, I saved $35 million. I saved $35 million and was able to funnel it back in to wages and other benefits, to giving premium breaks to the employers. And I say this because it's really important that when we think about the things that we do, and that when you start to say, okay, how do I want to do change? Change has to be a combined and a concerted joint effort. So next slide. All right, so now I've told you a little bit of the things you can do. I want to help you with some tools in which you can do it. So I have up here 4 tools that exist for every single employer. These are tools that you can use to figure out how much money you're spending. You can use it. Rand will tell you how much you compare. SAGE is a tool that is done by the the Employer Forum of Indiana. It's an amazing tool. All of these, the first 3 are free. The last one, they actually just announced on LinkedIn last week that they're gonna have a free version for employers. I don't know what it looks like, but all of these tools are tools that you can use to look at the hospital transparency files, how is your hospital in your neighborhood compared to others. The new SAGE tool actually will show you at a politician level, so you can, when you start to figure out what you want to be able to get done. This is amazing information. All right, next slide. But now I'm going to talk about my tools. Because I've got a few more minutes, I'm going to selfishly hawk 2 things that I have for you as well. We have a tool that if you go on our website, 32bjhealthinsights.org/interactive tools, you can put in your information and figure out how much would you save if you paid a percentage of Medicare. How much money would you save if you paid 100% of Medicare, 200% of Medicare? There's a few other things. It just gives you benchmarking data to show how much you are overpaying. And then the other piece is I have a template contract for you to use when you go out to RFP. You should talk to Michelle in the back. She and I have had lots of conversations about this contract. This is a template contract that you should use when you go to medical RFP. When you go to contracting, if you go to the next slide, the thing I will say is go out to RFP. RFPs are hard, they're time consuming, and they are worth it every single time. But one of the things is that when you think about your RFPs, one of the reasons we are giving away our template contract that we sent out when we did our RFP, we said sign our contract. I'm not going to lie, there were a few carriers that literally deleted the entire thing and inserted their standard language. We said try again. Because we wrote a contract that is based on the best interest of the employers. And in July, I will be launching another one that is on a PBM contract. We are in the middle of doing a PBM RFP, where we are also doing a contract first. As soon as we decide on the PBM, we will announce our template PBM contract. But you know why? I believe is that when we give away this information, we are doing better together. Because if we all get to use the same contracts, insurance carriers can no longer say, I don't do that. Okay, really? Because I see it in Cora's template contract, which means you maybe agreed to it. Call me, I'll let you know. The last piece I want to say on the things to do to drive change, next slide. Skip that one, move on, because I'm running out of time. I thought I'd be short. Is the intersection of benefits and policy. It's really easy to talk about benefits and change, but the reality is there are certain things we cannot do because of the institution, the healthcare industrial complex, and policy is where it happens. And it will happen through this organization, through state and federal legislation. I know Sean's going to talk about this a little bit at the end, but I encourage every employer in here is to understand what the policy implications are that's happening, and also to figure out what policy changes we need to do better. It's anti-competitive contracting terms. We're sponsoring site-neutral legislation in New York. We are figuring out how do we leverage policy to do the things that we don't have enough power to do through benefit design. Okay. So last question, because I'm pretty sure you're about to give me a 2-minute warning. Next slide is, what does it actually take to make this change happen? And I would say, and I took this quote, this woman is a leadership professor, and it says, the path to big systemic change is collective action, and that takes sister courage. So what does it take to actually make change happen? It takes courage to do it, even when it's hard, and it takes the collective action of the folks in this group. It's why the Washington Health Alliance, the National Alliance that they're a part of, the other employer coalitions, unions, your friends, when we do it together, we have the chance of actually making change happen. So you remember I started and I said, introduce yourself to the people standing around you. This is the room. These are your phone of friends. These are the people that you call when you say, I want to do this thing, is it crazy? Or I'm not sure I can, how do I do this? Or I've got this wild idea, do you want to do it with me? And so I want to end us there because I want to make sure that everyone understands there is no way that just Cora and the 32BJ Health Fund, or I was listening to the amazing employers that we're going to hear from this afternoon, we can't do it alone, and we have to do it together. Thank you.
Hello. Oh, there we go. Yes. So I invite our panelists to come join us. Cora's staying up here, so if you have questions for Cora specifically, you will get to ask those. Yeah. So I always assume that everyone knows me. But I'm seeing some faces in the room that I haven't seen before. So in case you don't know me, you haven't been on like a Zoom call or Teams meeting with me, I'm Denise Giambalvo. I'm Director of Member Engagement and Business Strategy at the Washington Health Alliance. And I am very happy to have this esteemed panel here with me. And if each of you will go down the line and introduce yourselves.
Is this on? All right. Matt Lund, CEO of Fortune Management, Inc. We're an employee benefit consulting firm here in Seattle, Washington.
Hello, Megan Peterson. I'm the director for the King County Office of Labor Relations.
Good afternoon. Carol Wilmus, the Director of Member Pooling Programs at the Association of Washington Cities. We're the service organization to the 281 cities and towns that are incorporated in the state. We have a large employee benefit trust.
Christina Johansson, Managing Director of Benefit Operations with the SEIU 775 Benefits Group. We have about 60,000 covered lives in our health trust.
And I'm Cora.
Thank you. We're going to kick this off with a couple of stories that we have to share. So I'm going to start with Matt, and then we're going to go to Carol, and then we have some questions for folks.
Well, as I mentioned, I'm Matt Lund. We work with mid to large size employers nationally and internationally in their benefit programs. And really what came about from our organization and our founding was that employers, regardless of size, got to that point of what do we do about the cost of the benefit programs? And what can we do? What can be done differently? How can we get back control or costs? What can we help our people do and be better at it? And so over the years as we work with them, there are different ways that are probably outside the norm on the way people look at benefit programs, but they become extremely effective for helping people gain access to healthcare. And I use that word, right? We're not talking about health insurance, because we actually talk about the less insurance you pay for, the more affordable healthcare becomes. And so through that avenue of working with our clients, and some of them date back 40 years where they've taken this approach, where they've looked at benefit programs differently, where the employers or the owners at that time said an $80 premium for a medical plan was too expensive, right? We all wish we could pay $80. But at that time, they started to look forward on what they could do, right? And so they've asked of us over the years is how can we continue to be innovative? How can you support us managing the cost, but along the line manage that member experience? And every organization has that delineation line that they'll work to, right? Some years they're more focused on financials. We need to be better at managing the costs, but we cannot sacrifice that member's experience. And so over the years, we've worked really closely. Some of you in here, Vera, Karam, over the years, we've worked with them very closely on managing that. Independent TPAs, those that are agnostic to the business decision that the employers are making to better serve those that they're supporting. PBMs, the reform of PBMs, making sure that you're doing the right thing. And along that line, making sure that member isn't left behind, right? And before it happens, before the event where they need healthcare, everyone in this room knows you're gonna go agnostically and exhaustively telling somebody about how the benefit program looks. They're gonna look at their premiums, say great, and hear nothing more until the event they need help. So what are you doing at that time? There's a new generation coming through that does not like to be seen in person, right? They want it done virtually. They want to have that ability to text. So how are you supporting them? And through that, when we talk about costs and what things look like, a lot of our plans over the last 10 years have seen costs increase no greater than 3%. That's real numbers. That's net benefit changes. It's not changing deductibles, where it's a cost shift. Co-pays, it's a cost shift. It's giving them options and opportunities to find better ways to access healthcare and better ways to be a better servant of themselves by giving them the tools and resources and support so they're not financially constrained to do it.
Well, I'm going to start with a story, and it will dial back many years, but I promise you that it will come full circle to today. So about 35 years ago, mental health care has always been a priority for the Association of Washington Cities and our Employee Benefit Trust program. It's a part of our total health management focus. And about 32 years ago, we had a case, a mental health case. It was a child, one of our employees' 15-year-old daughter, had a dual diagnosis, eating disorder and bipolar with suicidal tendencies. 35 years ago, a mental health benefit was a $10,000 annual maximum and a 15-visit limit per year. I know that's really hard to believe in today's world, but that was the reality then. This particular child was admitted to the hospital, suicidal, and she spent 34 days in the hospital, was never diagnosed, and was never treated. She was just kept safe from further harm to self. This was a daughter of a small rural city in Yakima County. The resources were very limited, and she was discharged. Our system failed her, it failed her family, and it failed that employer. So our board said, we have to do better. We have to do better. So the task to us as staff then in building a mental health plan that takes into consideration total health, including mental health. Mental health treated as equally as any physical diagnosis. So we sought out partners at the time that would help us to build that plan. And we had a lot of closed doors and closed ears at the time. It was a rather unheard of approach. This is before mental health parity was even whispered in the legislative hallways. So we sought out partners that actually were able to build a plan design, an innovative plan design. We brought it to our health plan, and the actuaries said that we were doomed to failure, that this was going to break our healthcare plan by opening up to unlimited healthcare access for those who have mental health diagnoses. What we know today, and dialing it forward now current time, is that that is absolutely not the case, right? That treating these diagnoses equally and providing resources, providing a benefit that matches that of any physical diagnosis, it has the ability to reduce our healthcare costs. And in our total health management program within the Association of Washington Cities, our data shows that our trend line is 2 to 3% lower than the local trend line. And those cities and towns that are able to embrace a full total health management program, their costs are 4% lower than all of our employers' costs within our fund. So mental health has continued to be a high priority focus of our program. It's a very accepted messaging within our employers and our employees and their families. We range 28 to 33% EAP utilization, highest of any customer of the EAP that we partner with. Today, we have a new challenge, and it's still with pediatric mental health care. We have a dearth of providers. We have a state, and we have 240 of the 281 cities are a part of our healthcare trust. Many of these medium to small cities across the state would never be able to access the kind of health plan, affordability, quality health care if they weren't a part of the effort that we put together for them as a trust fund. So we know that the pediatric mental health care just is woefully inadequate to address the needs of our children today, particularly post-COVID. So it continues to be a priority. Now, a godsend has actually been virtual care. However, and we have employers and employees in Eastern Washington, but also pockets of Western Washington that travel 120 to 150 miles to see their provider. And for many, that traveling, they don't have a car to do so. So access to care is just, a huge priority for us. Health equity is a huge priority. But what we're paying attention to today is, even though we've been able to overcome a barrier for access, is it the right care? And so continuing to stay in tune with getting resources to our patients that is the right care. I would also maybe just add on that a focus that was mentioned this morning from Julie from the city of Kirkland that is also a high priority in our mental health benefits is regarding our public safety personnel. Police and fire have a huge need with mental health resources, and of particular in the last 5 years. We know that the suicide rates are up in that population, and their stress and anxiety is very high. So how do we get resources that are trusted to them? Even though our EAP utilization and our mental health benefit is well utilized, within the police and fire population, it's not as highly utilized. So they are not as trusting of the benefit that is available to the masses, and they're telling us by their utilization that it's just not that right care that is able to help them and their family as they're going through a situation or help them to cope afterwards. So that continues to be a priority, and we're seeking out innovative vendors that will help us to put together a network of trusted therapists statewide. And I think statewide is really important. The resources that are available here in the I-5 corridor just don't exist outside of the I-5 corridor. And it's really important to our elected officials that that equity exists. So, a story to be continued.
Thank you. So hearing different scenarios here, right, and different needs based on population and geography, right? So we can't all do the same thing, and yet I think there are practices that we can follow that get us all to the same place, right? Which is the affordable care for all. That's high quality. Yeah. So I'd love to jump to Christina. Yeah, right.
Sure.
And
that's what I'm here for.
And so you operate on limited resources.
Yes, we do.
Right?
Yeah.
So another scenario for us, right? How do you make that work?
It's such an interesting thing, and current environment is making it a little bit more complex. I'm going to be honest. Like Cora, we are a health trust, union-affiliated health trust. It's a multi-employer plan. We provide benefits for home caregivers in the state of Washington, and we have a small population in Montana. Home care and long-term care in Washington is 100% Medicaid funded. As we all know, it doesn't matter what your industry is, funding is not unlimited. As prices rise, as we see hospital costs rise, as we see prescription costs rise, funding is not unlimited. We cannot just continue to pay high prices. And like Cora, we have low cost, high quality care. We have very limited cost shares. Our population is very price sensitive, and will defer or go without care if costs are too high. And so in these spaces where, we've always been really mindful of cost, and cost has always been a limiting factor for us, And as we go into an area where, we're really watching what's happening, in national and state landscapes as it relates to Medicaid funding, I think we have implemented quite a few plan design features that help us limit and drive cost to high quality care. Things like, making sure that cost shares to our participant population are very limited. We want people to be able to, and for cost to not be a barrier, to be able to seek out care and engage with care, primary care, preventative care. There's no cost share for any of these things. We have a very low prescription cost tier structure. And many services, there's no deductible, many services across the plan are provided at no cost to our participants because we want, our population has a high prevalence of chronic conditions. We want folks to be engaged in care. We're trying to drive that high quality care. But, on the same hand, we are able to, from a financial perspective, we offer care for caregivers themselves, for home caregivers themselves, and for their children. We are not yet able to provide full family coverage. So, that's our next big step. That's the thing that we want to get to. And so when we think about, what are the costs within our plan? What can we control? Where can we try to make sure that, we are financially positioned to, and our stakeholders, legislators understand the impact of being able to offer full family coverage. We are really mindful of cost. And in that space, it means making really hard decisions. It means your full board might want to be able to, cover GLP-1s at full cost. You want to do the things that might have those greater, long-term benefits, but oftentimes you have to take a stepped approach to get there. So I think the thing that I would encourage, kind of building off of what Cora has talked through, tools and tricks and tips to help us make change and help us kind of wrap our brains around change that's needed in the ecosystem. As we're looking at our data, as we're, hearing from our population both what they need and what they're ready to act on, I think the next step for us has been to take a phased approach. I know I can't afford GLP-1s. I can't afford, all of the centers of excellence and things like that I want to build a clinic. I want to have retiree medical coverage. I have big dreams, but I can't afford all of those things. And so as we think about even, getting to a place where we were able to offer coverage for caregivers' children, we took a stepped approach. We started with dental, vision, hearing, and then grew to a full benefits package, including medical coverage for kids. We're going to take the same approach to, spouses and partners. So as we try to undertake these really tough problems that, often come at a price tag, where we know that change is needed in the system, we take a little step, whatever we can do to start to build and get to the place that we'd like to see coverage for our population.
Thank you. Megan?
Gosh, well, there's a lot that I could say. I think I would start with just acknowledging the great work of Cora and her team, and so much of what you said really resonated. So in King County, we cover about 32,000 lives, and we're self-insured. We have a very successful labor management partnership going back 20 plus years. Our unions are at the table bargaining plan design changes. And one thing that has been really, really important in the change management space is educating them, not just about the dollars and cents, but what are centers of excellence? What does it mean to have health literacy? And as we have sort of moved the needle in terms of their education, we've been able to successfully bargain changes that meet both interests in terms of managing costs, bending the trend of rising healthcare costs, and then also just more quality. One thing that you said, Carol, that just sort of got me thinking about King County's journey is around equity and having mental health care providers that look like and come from the population that we serve. So we discovered in our EAP ranks that we largely had white and female, but also male providers. And when we surveyed our workforce, what we learned is people of color, a lot of our sort of line staff and field staff didn't feel comfortable going to those providers. So that really resonated. I would say most recently, in terms of the King County journey, we are really focused on our pharmacy spend. I agree that, sort of to Cora's point, that's not the end-all be-all. That should not be the singular focus. And as we have really gotten more educated about our contract, and currently we're with one of the top big three, we've realized that we didn't really understand what was going on in that space in a way that we should have. So King County was probably overcharged some $2 million in 2022 for GLP-1 drugs that should have been excluded. We're paying more for generics than our benchmarks. We really, I think, have embraced that we need help. And so, I know this tension, Cora, that you spoke of, like, do we really need another vendor point solution? Do we need another consultant? Sometimes you do. Sometimes you need to spend a little bit of money to really tackle these more intractable issues. And so we most recently have been working with a pharmacy consultant who has mined our contract and found many, many areas of opportunity. And so we're in the middle of an RFP. Hopefully we'll be partnering with a fully transparent PBM and potentially saving $5 to $10 million a year. So, we're not there yet. So today for me has been very much a day of motivation, and, I think you just have to keep plugging away. You can't despair, even though, listening to Greg Marchand and hearing that he's negated his trend, and I'm like, gosh, it's very clunky in the public sector world because you have so many red tape elements around contracting and RFPs. We have a whole prosecutor's office that has to review every one of our contracts. And so it's easy to lose sight of the kind of the overarching aim, but ultimately I think we're getting there, and it really has necessitated a partnership with our labor partners.
It's great, thank you. Yeah, I'm hearing education and buy-in through education, right? Data mining, contract mining, right? Which you touched on contracts, Cora, but we didn't really get into right, what that language actually says and the importance of having an expert to look at that.
Can I say something about that, Denise?
Yeah.
You need to read your own contract. No, you laugh, but the amount of employers whose broker or consultant reads the contract and they don't, I mean, and I think it's read your own contract. I'm like a part-time lawyer sometimes, I feel like. You want the contract to protect yourself. You want to also have it be where it's something you never have to use. But in the end, you also want to make sure that the asterisk in Exhibit C that contradicts and now eliminates all of the wins that you had over here, that you're aware of that. I mean, I will tell you, I have someone who wrote my own medical contract, still went live on January, and wondered why I was being billed for something that was an asterisk that we somehow missed in the contract. So it's about marginal improvements, but read your contract. Read your PBM contract, read your point solution contracts, read your ASO or TPA contracts. If you have a TPA that's not owned by one of the BUCAs, read that contract as well. It's so important that you understand what your benefit is being governed by, because you'll find out probably not your SBC. I shouldn't say that, because legally we're all governed by our SPDs, but the reality is the provider contracts with the carriers are going to supersede your benefit 100% of the time. And you don't know that if you don't read your contract.
And Cora, can I support that? Learn how to get out of it.
Oh, that's a good one too, yes.
Right? Like that can be one of the most financially, damning thing you could do is not know how to break up. Okay? And so we
In
see
life
it all
and
the
in
time.
contracts.
Right. And we see it all the time. In fact, there's a recent company we talked to, a very large organization, and we said, what happens when you leave? We'll be fine. Turns out they're not fine. Their PBM contract, they're going to be leaving hundreds and hundreds and hundreds of thousands of dollars behind because of this thing called rebates that they're leaving on the table and had no clue about.
Because there's no run out? Yeah.
Well, no, the PBM's going to keep it. It's very clear, you leave, we keep it, period, under any circumstance. So do understand how to say, it's great to meet you, but I also want to know what it's to say goodbye. And they should be willing to have that conversation in that moment. And by the way, your best moment to do it is before you've agreed to work together. That's your leverage. Don't wait till after the fact.
Don't give them the business before you sign the contract. In every other world except healthcare, you sign a contract before services are rendered. When you hire your broker or consultant, you've signed that SOW before they start working for you. But your ASO carrier, your PBM, I don't know, I'm not gonna lie, we may have signed our last amendment to our ASO contract 2 months before we signed our new contract. Like, these are just the realities of healthcare contracts. Nowhere else in business do we sign contracts after services are rendered.
Great point. Thank you. How are we on time? 15. Perfect. Good timing. I want to open it to the audience. So, questions. There has to be burning questions. Oh. Do we need a stretch break? Oh, here we go. Laura Kate.
Hi, everybody. I'm really struck with the panel that we have up here. It's inherently a panel that's really, and purchasers that are really focused on fiscal stewardship, because in many cases up there, you're focused on, you're using taxpayer dollars, you're using Medicaid dollars, you're using state dollars. I am curious how you have used that framing in order to focus on some of the harder affordability challenges and price control challenges, particularly around hospitals, and then also what other purchasers can use through the lens of the CAA around that financial stewardship and fiduciary responsibility in order for us to all work together, thinking about the dollars that we're using, the dollars we're leaving on the table, and fighting some of those really hard fights. Easy question. Yeah, Laura Kate.
Okay, I'll go in here. Hospital contract negotiations that have been coming up and challenged mid-contract renewal are very challenging for a healthcare plan that has set our rates. And when hospitals are depending on the system, could take up to 33 to 44% of our premium dollar, or 55. That ask is a lot, and we're going to be behind trend the next year. So we're going to fight, and we're going to support our negotiator for that trend. We have asked our elected officials in the areas that are impacted to join in that fight. Because the impact to the taxpayers of that community is significant. Unfortunately, this has less legs than it used to have because the ownership is no longer local. So we continue to fight that fight. Taxpayer dollars and the community's health many of whom who work in City Hall have far better benefits than those that they serve to pay to work for them. Our elected officials are very mindful of that. So that was a hard question. That's a difficult answer. It's difficult to do. It's not easy to do, but we attempted.
But I would say, when you asked specifically us about the Consolidated Appropriations Act, which means prices are now supposed to be public. So I also want to clarify that when I talk about hospital prices, and I'm going to assume I'm speaking on behalf of everyone here, we're not talking about the hardworking doctors and nurses who are probably not getting fairly compensated. It came up this morning, primary care docs not being fairly compensated. This is not a challenge with doctors. I would argue it's a challenge of why do you need a waterfall in the lobby of a hospital system? It's probably my real question. Or why are not-for-profit hospital systems having operating margins that are in the billions of dollars and their uncompensated care is less than 1%? I think there are real conversations that need to be had. And I think it is looking at tools like the Lown Institute, which does the compensated care components on how much are not-for-profit hospitals getting in tax benefits that they're not giving back to the community. You know, so I think there are things that we can do regardless of me being on the other side of the country. It's the same problems, right? And I don't know Washington's world well, but I'm assuming most of your hospitals are not-for-profit, but also probably have operating margins that are insane and are seeing 1% uncompensated care and maybe 20% Medicaid and Medicare, or 20% Medicare, 20% Medicaid. So that means the other 60% are commercial payers. It's commercial payers and working people that are having these price increases on the backs of them to offset their Medicaid and Medicare losses. And I have math that will show that they're not losing that much money. So if you want to know how to do the math, come find me. I mean, and so I think that's those are the conversations that we have to have, is what happens if they cut $800 billion from Medicaid? Turns out I can tell you that the 5 academic medical centers in New York aren't losing any money. I mean, they're losing money, but they're not losing money. They're not. Does a CEO need to make $2 million a year to run a hospital system that's not for profit? I'm not a CEO of a not-for-profit hospital system. So, I mean, I think those are the things that when we think about what are Consolidated Appropriations Act, what are your tools available, it is the fact that it's not, but I also want to reiterate, it is not the doctors and nurses. We're not seeing, that's not where people are not getting rich off of, it's the waterfalls in the lobbies.
I'd agree with that. I think it goes back to, we're talking about getting people access to healthcare. Healthcare is the doctors, it's the nurses, it's that team of people that help us be better, right? So how do we help those who are in the position to find those solutions and give them opportunities, give them knowledge, right? That's part of it. The way we access healthcare 20, 30, 40 years ago is different today. So we have to continue to evaluate and make sure it serves our population of people that we're supporting. But also don't take away that those providers are doing the best they can with the burden that's been put on top of them, that you have a panel of 5,000 people you have to see in 6 minutes to get it done, and or refer them to somewhere else because it generates money, right? So putting in those abilities for your people to make the best decisions and when they need it is when they're in there, right? And when we look at a lot of this across the United States, this isn't a Seattle area, this isn't a New York issue, it's a US issue, right? And all of our clients that we get a chance to work with, they all have the same problem. Doesn't matter the industry you serve or the people that you represent, it's all the same stuff. Costs are going up and access to healthcare is dropping. So what can you do to help them? And that's continually innovate, be creative, think outside the box. Challenge your people to look at it differently and say, but collectively, if we do this as one, we will win. But you gotta do it together, and you gotta have the messaging. You gotta be proactive. Don't wait. Because if you're sitting in here today going, wait, there's a different way to do it, you're probably behind the 8 ball. Probably financially way behind. Because these ideas have been around for a long, long time. But it is something that we always talk about. Don't do change for change's sake. Don't be emotional about your change either. Be pragmatic, be thoughtful. Do actionable items that you can do to help everybody get to where they need to be. And it's doable. And by the way, you don't have to be a 200,000 life group of people. You can be a 50 life group of people and do the exact same thing. So just do know that there's options and take the chance. learn about it. Not every solution is the right one for you, but learn about it.
Okay, go ahead.
I already beat the primary care thing over the head, so let me change gears. Has anybody in the room heard of Happy the Movement? I didn't think so. Here's an innovative concept. I, as an employee, don't trust my EAP because it's owned by my employer. Does that resonate with anybody? So I won't go to the EAP. What if instead a company decided to hire some lay people who just are good listeners to call up every employee and say, how are you doing? That's what Happy the Movement does. And in doing so, their statistics say that they can double the use of EAP, and the medical cost offset pays for the whole thing. Because by accessing mental health when it's needed, people don't spend their money at the doctor's office with a bellyache, a headache, or chest pain, which is actually anxiety and stress, and costs a whole lot more. So happythemovement.com, and no, I don't make any money from them.
Thank you. Love that. Again, how are we on time? 5 minutes? Okay. I was going.
Megan, I know you talked about looking at consultants, and I know one of the red flags is kickbacks from the consultants. So how do you go about finding a consultant that doesn't have that conflict of interest in terms of, I get so much dollars for steering you to this PBM or this healthcare system?
Well, in King County, we have heavily regulated procurements, and so a lot of the rules are set up to vet all of those issues. I might invite my colleague, actually Michelle, who is closer to our RFP process, to speak to some of the tips.
While you walk that to Michelle, I was gonna say, there's also the 408B2 disclosures, which is your consultant and broker disclosure form, and this also came under the Consolidated Appropriations Act. I think they can be gamed, but that's, see, again, I say the quiet parts out loud. But in theory, every consultant, before you sign with them, or your broker, should fill out their broker disclosure form. And I would actually like the consultant on the panel to talk through this. I think what you're going to find is more and more consultants are figuring out to say in their disclosure that the work they do for you, they are only being paid for by your fees. The problem is there's a loophole, is what I would call it, in the law that says if they're getting fees over here, but the work they're doing for you is not related, pay no attention to the fees behind the curtain, you're never going to hear about the fees behind the curtain. You should ask about the fees behind the curtain, but again, pay no attention to the fees behind the curtain. But I think it's the fact that we're even talking about it is a step in the right direction. I think the other thing I would say is there are consulting companies out there that only take consulting fees, and we need to be more public about who they are. Sorry, now Michelle, I'll let you answer.
No, I'm glad you brought that up, Cora, because the part that's happening behind the curtain can be a really large amount that is more than what they're making off of the employers. So the other part of it is to talk with other employers and find folks you can trust to talk about, like the Washington Health Alliance. There's also Purchasers Business Group on Health. I was going to make a crass joke, but I'll save that for later. With respect to the pharmacy benefit, we did, before we did an RFP for the PBM, we did an RFP for a pharmacy benefit consultant, and we did, we had an attorney that we got a recommendation for who wrote up an attestation that they would need to sign before we would consider the proposals, that they do not take any money whatsoever from PBMs in any way, shape, or form. And we had an attorney write it up, so I think it was pretty bulletproof. So I think, for us, a big part of it was getting the right experts and making use of your contacts and getting referrals to consultants you can trust. So that was part of it for us.
If I could just add that this whole sort of idea of working with a pharmacy consultant came from the WHA. So Michelle had a meeting with Drew, and before I knew it, we were going down this path, and it's been a really good thing. So it's another example of the value that the Alliance brings.
And Cora, if you want me to, question your consultant and broker on how they're paid, period. Okay? We play a role in what you pay for. We also get paid, in a lot of incidents, more than what we're disclosing. Contingencies, overrides. One, big one. Secondarily, I talked earlier about that organization. We found that they're leaving behind all the rebates. They also didn't know that they were paying that broker $2 per claim under the PBM. I want you to, it's 1,500 employee lives. Every claim, that broker was getting paid $2 on top of the fee they disclosed. So please do pay attention to it. I'm sure I've just disappointed a lot of people in this room about that.
That's at least $5,000 a month.
At least. Absolute at least. And so those things are really important. So as you're choosing your partners, there's pieces of every single part of that partnership that you do have to ask questions about. And don't be afraid to do it. And don't be afraid to do it every year. Because a lot of contracts may have you bound for multiple years, but check inside the provisions on how they're paid, what the payments are, timing of payments, right? Because those are really important things to know. But yeah, and I raised my hand earlier, we are paid a PEPM or an annual fee. So when we sit down to talk to you and say, here's our recommendation and why, I have zero other objective than we believe it's in your best interest. Whether you agree or not, wholly different conversation. But please do look at that, because Cora is correct. The amount of money that is flowing is interesting, and please be aware of it, because you're signing off on that, whether you're aware of it, especially if you don't ask.
Okay.
Can I sneak in there? This is great. Appreciate this panel. You all are like the wizards of healthcare. So this is fantastic to hear. I also feel like I should become a PBM consultant. $2 a claim.
100%.
There's a lot of opportunity.
Yeah, I need to update my resume. So I guess for the panel, two questions. One question is, I feel like we've been hearing really great detail on sort of the administrative side of the benefit. I'm curious, from your POV, how involved are you or can you be in the formulary decision-making process? How important is that to you? How much weight can you throw around if you have carve-outs or carve-ins that you want to make on a formulary? Maybe it's mid-year, off-contract cycle to take care of members in your population. And then related to that, my question is, how much visibility, like how in tune are you to individual members in the claims data? Is it through the TPA or otherwise? To track and notice, like, hey, we have these 10 individuals that if no intervention takes place, they're on track to an inpatient hospital stay. Is that something that's surfaced, like in my experience, right? It's like quarterly or end of year. Is that still the case, or are there tools that you have so that you can actually get ahead of that? Thank you.
I'll start. We have tried to engage our unions around formulary changes to more generics without success so far. It's a very disruptive change. As your costs continue to climb, I think it's worth taking a shot at the table, to talk to the workforce and their union representatives about that. In terms of how you can in real time keep tabs on these kind of more complicated cases, there are programs out there. We have a program called Specific Care. It's a case manager sort of model where certain things get flagged, and then there's a nurse or provider assigned and is contacting that individual regularly and trying to steer them in a way that makes sense and follows best practices.
Yeah, I would say it goes back to when you're hiring a TPA, and I use TPA, right? The person who administers your health plan, that they're transparent in the reporting that they give you. You request the timing. The TPAs work with daily. We know daily about claims. And we get notifications sent when there's a large claimant coming, it's procured, it's be pre-cert, pre-auth, so that we're notified. In regard to your formulary conversation, it depends upon the PBM you choose, right? There's transparent PBMs that are out there that'll let you make mid-year decisions, make changes. It's your formulary, right? Now, if you're governed by the rebate game, you're chasing rebates, and that's what your methodology of choosing a PBM, please rethink that, I would say. But there's absolutely different ways that you can have a different managed relationship with a PBM that allows you to make it your PBM, makes it work on your behalf, and you can do different programs to help manage specialty drug costs, as an example, right? Which is one of the fastest, GLPs being part of that. But other drugs that are in there, there's different ways that you can procure the exact same drug at a different cost than through a normal formulary arrangement, and allow that flexibility that you're making the decision so it's at no cost to your member. What a great idea, right? And it saves the plan millions of dollars in some instances.
But I would also come back full circle and say, read your contract, because you probably don't have any rights to do any of those things in your contract today. And so if you look at formulary, you probably don't have the right in your contract to edit the formulary because you're taking a formulary from the PBM. And look, one of the things I wanted to say, because it comes up in a lot of panels, is if you're with a big 3 PBM, that's okay. If you're with an ASO in the one with a Blues, United, Cigna, Aetna, that's okay. We all get to be where we are as plans, right? I have Anthem and I have Optum. So I'm saying here right now, like I have, the people that are the big bads, but you know what? They work for me right now. And so I want to say, like, you don't have to go and be the most transparent PBM. You don't have to go with an independent TPA to still have your needs met. But you've got to have the contracts that protect you to do so. And so from a formulary perspective, I think that I would also challenge you and say, where do you get your data? So formulary or high cost claims, all the same, is where is your data and where are your members spending the money? Because I think we spend a lot of time talking about PBMs, which is maybe 25% of what you're spending on. And I'm not saying don't focus on the 25% because it absolutely matters. But if all of your money is because 3/4 of your members are having unnecessary care or getting colonoscopies at an inpatient facility instead of an outpatient or an ASC, spend your time and energy there, I guess is what I would say. Because oftentimes I think it's really, we get anxious about the things that we hear about in the news, but I would say, like, pick a step, pick one baby step to kind of figure out what you want to focus on, because there's too many things to focus on. I've got a laundry list of things that people say, well, how come you're not insert thing here? I don't know, because I'm doing the thing over here. So I would just say, like, it's okay, you don't have to do everything, I guess is the other thing I would say.
I would echo that. We can't solve all the problems in the world. And then, as we pick, one thing, 2 things, 3 things that we're going to tackle this year or this biennium, we also leverage incentives. So, kind of to the formulary question, like where we're able to influence the formulary, add a value-based tier structure, like that is at no cost or $4, like really low costs, we're driving folks to, be taking those maintenance medications. So I think that's also something to consider, is like really small price cuts or incentives, the other ways. It matters. People will go to a preventative dental exam for $25. And they have not gone in years, and they'll go for $25. So I think there are ways to even, think creatively, out of the box, different way, different approach to drive the care that you want to see in your health plan that makes that longer term savings and impact.
Okay, so I'm just I'll wrap up here, and our mission at the Alliance is to improve access, affordability, and quality of care in our state, and we can't boil the ocean, as everyone here has pointed out. It's done incrementally, and we have to start somewhere. And I was telling Matt earlier that we have 4 of our purchaser members running RFPs for PBMs this year, and I think we have 5, maybe 6 also running on the medical side. So to me, that's us helping to drive change, because regardless of who they choose, right, they're thinking about things differently. And I will say that they weren't thinking about it a year ago, but it was a result of what they learned through us, from each other, that prompted them to go down that path. So I thank everyone here for this discussion and for our whole morning, and we're going to transition over to policy. But it's these conversations that really help keep us moving forward and help us chip away at our mission. So thank you. There we go. I got my mic back. I am really pleased to introduce Sean Greminger. What year did you go to work for PBGH? Yeah. Yeah, so we met I'm going to say 5 years ago. Sean was working for Purchaser Business Group on health, doing some lobbying. We don't call it lobbying, because they're not, there you go, issue education. And I very quickly recognized that when it came to policy, he was the smartest man in the room, and greatly appreciate what I have learned from him, and that he is now with the National Alliance of Healthcare Purchaser Coalitions as their president and CEO, and continues to lead all of us by example, and continues to pass his fabulous knowledge on to us. And so, Sean.
How about that? There we go. Thank you very much, Denise. I want to say thank you to all of you for being here. So as you can see, I will explain the Mariners hat in a minute. I grew up around here. Actually, I grew up in Kirkland. Is the Kirkland person still here? City of Kirkland? Oh, she left. That's a shame. Great place to grow up. Great. I always love the opportunity to come back to Seattle, I've been in DC for 25 years now, and this is still very much my hometown. I'm still a diehard Mariners fan. And I'm going to tell you why that's frustrating. So can we go to the next slide? Key takeaway from today, before we even get into policy. Don't be like these guys. That's Jorge Polanco striking out. The Seattle Mariners led the league in strikeouts last year. In fact, I think they set a record for strikeouts last year. Why should you not be like the Seattle Mariners? Does anybody want to, do we have any sports fans here? Yeah. So the Seattle Mariners have missed the playoffs by one game. They play 162 games a year, I think. They've missed the playoffs by one game 2 consecutive years. What would you do during the offseason when you miss the playoffs by one game for 2 consecutive years? Practice, do anything. Just do something. Guess what the Mariners did during the offseason? They did nothing. They didn't get a new player. They have the best starting rotation in America. They've got great pitchers. They have terrible offense. Did they pick up an offensive player? Did they go out into the free market? No, they did nothing. So guess what's going to happen? They're going to miss the playoffs by one game again this year. I'm taking my hat off because I'm so frustrated. And it feels weird to have a baseball hat on for my presentation. So my key takeaway would be, please do something. Do something. There are so many things you can do. This terrific panel talked to you a lot about it. I know all of you are really active. You wouldn't be members of the Washington Health Alliance if you weren't. All right, now I'm going to talk about policy. I'm going to speak fairly quickly because I have a limited amount of time. I've got a lot to cover, and I want to make sure there's time for Q&A. Here's our agenda. We're going to talk about what's happening in DC. I want to talk about budget reconciliation, a budget process that you've never heard of, but which is really important. I want to talk about our priorities. These are not the only priorities, but these are the ones that I'm going to do sort of a deep dive on. And then I want to talk about what's an employer to do. So first, what's happening in DC? No, seriously, I've been doing this for 25 years. I have no idea what's happening in DC. We have no precedent for what's going on. I would like to. I would love to spend half an hour talking about the craziness that's going on in DC. We're going to focus on the things that we can actually do something about right now. So I asked my colleague to put together a slide, and I was like, I just want something. I want like hurdles and like people jumping over hurdles, and it's like members of Congress. And so she put this into a an AI tool, and this just I want to say says something about like why AI still needs some work and why actually it has a lot to do with, because it's kind of cool, right? We've got hurdles, we've got congressmen jumping over, we've got the Capitol in the background, but all she said was congressmen jumping over hurdles, and look at what they put. It's 3 white guys who I think all look like they're from a particular political party with red ties. So it's interesting when you ask AI to do something and you're like, show me congressmen, and this is what AI thinks congressman looks like. Interestingly, starting in about 2014, I believe, was the first time that a caucus, a party within Congress, was actually was majority female and/or people of color, and that was the Democratic Party starting in 2014. Has been that way ever since. So this is obviously not representative of what Congress looks like anymore. But anyway, it's still a helpful slide. So there's sort of 3 major things that we have to do in DC. We've got to deal with the funding bill, which actually they jumped over that hurdle last week. Budget reconciliation, which is going to take up a whole lot of time and maybe fail, which would actually probably be okay. And then we're going to actually finally be able to talk about meaningful health policy. So let's go to our next slide. So there's a lot of text here. What you need to know is Congress, they've got to pass an annual budget resolution to sort of keep the government funded. They did manage, they were going to do that in December, and we were this close, like literally like 1 yard line, or I don't know, for the Mariners, like it was like in a home run, and then like Elon Musk jumped up and like snagged it from over the wall to getting what would have been the most comprehensive PBM reform legislation in history across the finish line. It was Democrats, Republicans, broadly supported. It was in the bill. I read it. It was right there, and they were going to vote on it the next day. And Elon Musk sent out a tweet saying, in essence, I don't know, this bill seems pretty long. And guess what happened? So that and most of everything else that was in that bill got stripped out, other than a 3-month government funding extension. That lasted until March. They ended up passing the March package, which funds the government through the end of the fiscal year, which is September 30th, and we got nothing. And so we missed the opportunity to pass the most significant PBM reform legislation ever, despite the fact that it's actually supported by like 98% of Congress. We're going to come back to it. But it does mean that we are now on to step 2, which is budget reconciliation. So we'll go to the next slide. So budget reconciliation is a process that was designed in 1974. We thought we spent too much money in 1974. Can you imagine that? We thought our deficit was too big. And so they said, it's really hard to raise taxes and cut entitlements. It's just really hard to do, right? It's unpopular in most cases. Let's make a process that's easier to be able to do those things that can actually reconcile the budget and make the country more affordable. And what they came up with was the idea that it's a complicated process, but if you pass a budget resolution that directs the congressional committees to save money, they each have to then go out and find ways to save money by either cutting entitlements or raising taxes. And to make it easier, we will say that that bill cannot be filibustered in the Senate, which means you can pass it with a simple 51-vote majority and instead of having to get the full 60. In the end, budget reconciliation has been used more often than not to actually increase the budget deficit. Don't ask. So by definition, it's a partisan exercise because the only time you use a budget reconciliation bill is when your party is in control of the House, the Senate, and the White House, right? If you had to work on the other side, the resolution would never go anywhere. Democrats have used budget reconciliation. Republicans have used budget reconciliation. Most of the major tax cuts passed by Republican presidents have been using a budget reconciliation process, and the Affordable Care Act and the Inflation Reduction Act, which is what imposed new Medicare negotiation. All of those happen in budget reconciliation. So Republicans are intent that they're going to pass a reconciliation bill this year. There are things that can be included in it. So you can see included provisions. These are all things that have been discussed. But there's this thing called the Byrd Rule, which is named for Robert Byrd, who you may remember being like ancient when he finally passed away in his seat in the Senate. I think he was 101. Basically, it says that you can only include entitlement spending and taxes. Those are the only things that can really fit into a budget reconciliation bill. Anything else can't be in there. What that means for us is that it's actually most of the stuff that we care about, regulations in the commercial market sector, you can't get into a budget reconciliation bill. So for those of us who are working in DC, it's sort of a frustrating thing because we're like, well, we have to wait for 9 months while Republicans sort of work this through. And I think probably end up coming back to the conclusion of we only have a 3-vote majority in the House of Representatives, which is the most narrowest majority in over 100 years, and so it's probably not going to end up working out. And you sort of just want to tell them, be like, guys, it's not going to work. Can we just skip it, just go to the next thing, because it's not going to happen? But they're going to have to learn their lesson, and they'll figure it out 9 months later when it fails. I could, by the way, be very wrong on that. They may end up passing something, but so it could include a couple of things we like. It'll also include a lot of things that we don't particularly love. So the big one that everybody's talking a lot about is Medicaid cuts. There's a lot of discussion out there about, we're just going to root out waste, fraud, and abuse. $880 billion worth of waste, fraud, and abuse, evidently, because that's what the Energy and Commerce has been told to save, Energy and Commerce Committee. It does include could include site-neutral payments, which is something that I think has been talked about on the stage today. But the idea that Medicare will stop paying hospitals more money to do the same thing that a private practice physician can do. So it gets rid of facility fees, something we very much support. And frankly, the only reason that we haven't passed site-neutral payment is the senior senator from New York, Chuck Schumer, who is, I was going to say in the tank, but if hospitals don't like it, it will not happen. Yeah. And so we've been stuck with, all of us as taxpayers and as Medicare beneficiaries, paying a lot more for hospital services than we need to, in large part because Chuck Schumer really likes local hospitals. If you do it through the reconciliation, though, Chuck Schumer is going to vote no on that bill no matter what, and you only need 51 votes in the Senate. Anyway, all of this is to say, the next 9 months, we're going to be spent talking about stuff that is not really on our agenda. So let's go to the next slide. By the way, I have actually come up with a really interesting strategy about how we could get our issues into budget reconciliation, which is to go after hospitals' tax-exempt status. Because that fits into the IRS code, that's taxation, and if you say, hey, maybe if you don't provide that much charity care and you make a boatload of money on the commercial side and you participate in 340B and you engage in anti-competitive practices and you don't participate or you don't fully provide transparency per the law, maybe you lose your tax-exempt status. Maybe. In which case, that should fit into budget reconciliation. We'll see. I don't know. I don't know if it'll work. That's my idea. Okay, so our top priorities. Again, I'm going to go into more detail on 3 of them. But a big one is defending ERISA preemption. I think if you are, how many of you, by show of hands, have a significant number of employees across state lines? A couple of you? How many of you are pretty much all Washington State? All right, so for all of you who are all Washington State, I'm sorry, but most of the employers that I represent through our coalitions have people all over the country. There's a reason that we like ERISA. Obviously, I think, hopefully you guys all know what ERISA is. If not, we can talk more. But one of the things that ERISA says is that the states can't directly regulate your plans. We generally think that's a good idea because if you're Boeing or Walmart or 32BJ, you don't want to have to comply with dozens of different state regulations. You want to have one standard that you can work with, and that's what ERISA does. It creates a federal standard. So we want to defend that. There are some people who actually want to sort of weaken ERISA. We're not in favor. It's not a top priority for the National Alliance because there are other people. There's an entire organization called the ERISA Industry Committee, which is a partner, and that's literally the thing they do. All right, ensured data access and transparency. I'm going to talk a little bit more about this, no, let's do it here. So by show of hands, who here is here as representing as an employer purchaser? A lot of this table, some folks over here. Who do you think owns your claims data? Do you think you own your claims data? Or do you think your carrier owns your claims data? You do. Does anybody think the carrier owns it? Any carriers in the room want to speak up for the idea that they own somebody else's data? All right, good. There are effing receipts. We own our own data. So, as you may know, if you're an employer and you've tried to get access to your own data, sometimes it's really challenging. We believe the Consolidated Appropriations Act makes clear something that has been around for a long time, which is we own our own data. But there is now there's better legislation out there, the Price 2.0 Act, which we'll talk about in a few minutes, which creates an affirmative right to say we, as employers, in the self-insured space, have full ability to access, audit, and use our own data. I was talking to a carrier, not yours, at a place in Minnetonka, Minnesota, just randomly. That's where I was when I was talking to this carrier. And I was like, well, we own the data. And they're like, well, I don't mind giving you access to the data. I just want to know, like, what are you going to do with it? Like, just help us know what you want to do with it, and then we can make sure we're giving you the right things. And I didn't say this, but what I wanted to say is, like, you know what I want to do is I want to print it out, I want to take it to a bonfire, and I want to burn it, because it's my flippin' data. I can do whatever the hell I want with it. You don't get to tell me what I get to do with something that I own. I was nicer than that. Maybe I shouldn't have been. So this is a top priority for the National Alliance, I think for obvious reasons. If employers actually finally have access to, and some of them do, Cora does better than most, we actually have access to real actionable insights. We can actually design our health plan the ways that we want and not be dependent on sort of third parties to tell us what we want. Lowering prescription drug prices, I'm going to talk more about PBMs here in a second. In general, in the past, Republicans have been very defensive about the pharmaceutical industry, and they've largely sort of done what pharma wants. That is starting to change, in part, credit where it's due. President Trump has, I think, changed the conversation within the Republican Party about the role of pharma. But there are now other Republicans on the Hill. John Cornyn, who's from Texas, has been big on this idea of, like, let's ban some of the patently anti-competitive practices by drug makers. So the big thing that, and these are sort of three different ways that this happened, but the big thing that drug makers, name brand drug makers, try to do is, they have when you have a patent and you have market exclusivity, you have a monopoly. And when you have a monopoly, you can charge whatever you want. And so, if you happen to own a drug like Humira, you're going to make a lot more money while it's still under patent than when it goes off patent. And so drug companies have been very active in things like creating patent thickets. I think Humira at one point had 85 patents on one drug. Patent evergreening, where basically your patent's about to expire, but they find something else within that drug to patent and be like, oh, well, now we're patenting that. Now we get another patent for another 7 years. Product hopping, so this is basically like you're about to roll off Humira. What's the one that replaced Humira? Skyrizi? Yeah. And Rinvoq. Whatever, they're all dumb names. Your patent's about to expire, and they're like, yeah, okay, but that's the old Humira. I've got a new Humira, which is actually 99% the same, but it's a teeny bit better, and now I'm going to put it under patent, and I'm going to pay the PBMs to make sure that they cover that instead of the old one, and I'm going to keep making money. So we want to ban that as well. And we're going to talk more about 340B. And then reestablishing competition in the hospital market. There's so much to say here. Cora's, I think, said a lot of it. I think we would love to be able to stop anti-competitive hospital mergers, as you've probably heard many times. The Federal Trade Commission has very rarely steps in to stop what are clearly anti-competitive hospital mergers. In the end, in some ways I feel like the cat's out of the bag, right? Ascension is what it is. Providence is what it is. They can buy more hospitals, but they already have a dominant market space. By the way, Cora mentioned the Lown Institute. It's definitely worth going to their website, looking at sort of what is the value of the tax exemption they get and what is the value that they provide in terms of community benefit and charity care. Do you want to know which health system has the largest charity care deficit? Excuse me, the largest, I think they call it fair share deficit. Providence. Yeah. I was a hospital lobbyist for 13 years. I've used those words unironically. Enacting site neutral payments we talked about. and then banning anti-competitive contracts, in addition to the sort of price transparency stuff that we've talked about. The banning anti-competitive contract stuff actually comes out of the West Coast. It comes out of the Sutter Health settlement out in California that you probably know. After being sued by unions, and then PBGH joined as a co-plaintiff on behalf of their employers, and then ultimately by the state of California, Sutter agreed that we won't do things that are patently anti-competitive for like 10 years, and we'll pay back some money to the employers. And PBGH, and I was there when we started working on this legislation, we're like, well, if Sutter can't do that thing, maybe nobody should be able to do that thing. Like, maybe you shouldn't be able to say it's an all or nothing contract, or it's an anti-tiering, anti-steering contract where the employer has no ability to say, hey, you're overpriced, I'll keep you in my network, but the copay is gonna be higher. Like, maybe we should just ban that nationwide. We've made some progress. Yeah, you'd love that, right? If you could just say to Presby to be like, no, you know, if I just wanna buy maternity care from you, we will have a conversation about maternity care. You can't force me to buy everything else. It's a priority. We've struggled, frankly, to get there. But that gives you an idea of sort of where we see the future. You can tell from the National Alliance perspective, it's all about value, it's all about costs. All right, next slide. So the legislation that I was mentioning around price transparency, you can say I bolded grants group health plans the right to access, audit, and review claims data. This legislation is really the gold standard. By the way, Corey, you can tell Cynthia Fisher that I put this up on a thing, and I said, yeah, you could take a picture of me. There's a friend who called me out at my own annual meeting in front of 500 people because I wasn't doing enough to support her bill. Whatever. So it's an excellent bill. This would be really the gold standard for price transparency. And I think the biggest thing out of all of these items is the idea that we would have access to our own data. And there's nothing that a carrier or anybody else can do to deny it. We don't think that price transparency is the only thing we need. Cynthia disagrees. She actually thinks that's sort of the end result. And once you have that, the free market will work perfectly. I've sort of made the case to be like, I don't know, if you're in Northern California, you can know Sutter is way overpriced. You're still paying too much money. But it would be incredibly helpful. And it is amazing that after, I don't know, 8 years after the hospital price transparency rule was enacted or was created by the Trump administration, maybe it's more like 5 years, depending on who you ask, a third of hospitals still do not provide fully compliant price transparency. And the Biden administration, to their immense discredit, fined 15 hospitals, even though there's probably 1,000 that should be getting monthly fines because they haven't been fully transparent. Next slide. President Trump did issue an executive order on hospital pricing, on hospital price transparency. I'll just, I'm trying to be as nonpartisan as I can. It was good. It's a good executive order. Thing to know about executive orders, and everybody talks about, oh, President Trump's signing all these executive orders. Most executive orders look like this one, which is they actually don't do anything. They just direct other people in the government to do things. So as you can see, for instance, mandates implementation and enforcement of healthcare price transparency regulations. So he said, hey, you have to actually implement and enforce these things. It directs the Departments of Treasury, Labor, and Health and Human Services to implement and enforce blah, 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 blah. In the end, it's actually the regulators that are gonna have to do these things. Just a thought. You may want people in those desks to actually be able to do it. Just a thought, I don't know. Because if they're not there, they're not enforcing the laws and the regulations that you just wrote. But I don't think they're listening to me on that particular point. Next slide. So going back to sort of the PBM legislation, this is a top priority for the National Alliance. I was very proud. This was a lifelong dream. I got to testify in Congress. We testified in strong favor of the bill that we discussed back in December. This was sort of a last-ditch attempt to try to get it across the finish line in March. We failed. We're not giving up on this. PBMs are, I think, the most unregulated aspect of the healthcare industry today. When I first started working at PBGH, actually, and being like, so who regulates PBMs? Right? And I started going to smart people, and I was like, where in, like, just show me the statute. Like, I'm not a lawyer, but I spend a lot of time reading, statute. Like, just where's the PBM regulation part? And they're like, That's not a thing. We don't have that. We regulate self-insured plans. We regulate fully insured plans. We don't directly regulate PBMs. It's just not there. So shocking that they can get away with some of the stuff they get away with because there's nothing there. The bill that was before us, and then again, I have some hope that in the longer term we will get across the finish line, for the first time would actually regulate PBMs. And I think the thing that I wanted to note, so I'll just say quickly, it did a lot of things. The thing that in some ways is the most important is it provides end-to-end price transparency. Now, I will also say PBMs will always find a way to get around things, sort of like our consultant broker friends, some of them. Are you guys all familiar with what a group purchasing organization is in the context of PBMs, sometimes also called a rebate aggregator? Okay, so in the very long chain between the drug maker and you, or the patient, there are a lot of entities. The one that most people have not heard of is the group purchasing organization or rebate aggregator. They are owned by the big three PBMs. There's actually a couple more. They will say, if you're, who owns Zinc? CVS. Zinc is always the one I remember, maybe because it's a sort of more clever name than the others. So if you go as a purchaser and you say, hey, I want a full rebate pass-through contract, CVS will be like, no problem. You're getting 100% of the rebates from CVS. If you then say, okay, but I want the rebates from Zinc, they'll be like, who? That's some company based over in Ireland. I don't know those guys. No, they are a wholly owned subsidiary of CVS. They're in Ireland, I think, or maybe the Cayman Islands, I can't remember which one. Switzerland? They're in Switzerland, all right, so it's they're not in the United States. By the way, if you look up, you go to LinkedIn and look up people who work at Zinc, there's 3 of them, because it's a figment, it's just there to create another layer, so that way when Zinc goes to Pfizer and says, hey, I want to contract on your drugs, and they negotiate rebates, Zinc can then hold on to 30% of that, and then they sell it to CVS, and then everything else flows through, and they get to tell the employer, you got a full rebate contract. So this bill would say, no, you can't do that anymore. We need to know what was the initial price of the drug, what was the rebate that Zinc got, what was the rebate that CVS got, what other discounts were there, what other fees are there. You have to describe what those fees are. They actually have to be bona fide service fees tied to something. Did you refer internally to your own mail order specialty retail pharmacy? I don't know. So it would provide actual end-to-end transparency. At least that's how it's designed. The other thing it would do is it does different things for different markets. So in the Medicaid market, it would ban spread pricing. In the Medicare market, it would require what's called, now I'm forgetting the word. It would make sure that basically any fees are not tied to the price of the drug, right? So you don't get paid more if the drug is more expensive. It's sort of a flat fee. In the self-insured commercial market, it would do 3 things. It would do price transparency. It would mandate rebate pass-through. So they would still be allowed to do spread pricing, though they would at least have to disclose it to you. But at least your rebates would be passed all the way through. And it would, forgetting, see, no, it's been too long since I did that presentation. It would do one more thing. No, I'm just thinking about the specific 3 things that the bill legislates. Well, it's up on our website. You can read the full letter. It would have been really strong legislation. I encourage all of you to, we'll get to what you guys can do in a few minutes, but I would encourage all of you to support the ability of basically to re-empower employers in their negotiations with PBMs. Next slide. All right. This is my obligatory couple minutes on 340B. Where to start? I've done full hour-long presentations and run out of time, so this one I have to do in 3 minutes. 340B was created in 1992. It was initially designed to enable certain safety net providers, community health centers, and 90 urban hospitals, think Harborview, to purchase drugs at a discount. The reason they did this was because in 1990, Congress passed the Medicaid best price rule, and basically saying that whatever best price is that you're giving out in the market, you have to give that to Medicaid. And previously, a lot of drug companies were actually offering discounts to safety net providers to say, hey, you're a safety net, doesn't cost us that much money anyway. We'll just give you our drugs a little bit cheaper. But once they started doing that, they were like, well, if I give you the drug, if I give Harborview the drug at a discount, now I have to give that to everything in Medicaid. I can't afford to do that. So they took away those. Not surprisingly, the community health centers and the hospitals went to Congress and they said, hey, this is a problem. They were like, cool, no problem. We'll come up with this very little technical thing. So small, we didn't even bother giving it a name. It's called 340B because it's literally Section 340B of the Public Health Service Act. That's how small this was supposed to be. And it stayed pretty small. I first started working on 340B in 2005. That is not why this slide is set at 2005. It's just convenient. That's really the first year where there started to be some decent reporting on this. I will admit I was lobbyist for the Children's Hospital Association in 2007 when we got freestanding children's hospitals into the program. I'm sorry. And then I was at the public hospitals from 2009 to 2017. And we saw a real fundamental change in the nature of 340B over the course of the years that you see here. A couple of things happened. A couple of new hospital eligibility types were added, critical access hospitals, et cetera. Doesn't really add a lot in terms of price. But the ACA Medicaid expansion occurred. In 1992, roughly 12% of the people in the United States were covered by Medicaid. Does anybody know what the number is today? 25%. It depends on the state. Some states it's much higher. California, it's like 35% of people. The eligibility to get into 340B as a DSH hospital, as a freestanding acute care hospital, was set in 1992 at 11.75% of your DSH adjustment. You don't need to know how that calculates, other than basically if roughly 12% of your patients are covered by Medicaid or are low-income Medicare beneficiaries, you get to be in 340B. Well, in 1992, there were like 90 hospitals that qualified. Today, a majority of hospitals in the United States are in 340B. Providence, it's not just Harborview now, it's not just UW, it's all the ones you know. You think about it, 12%, that's not all that many, right, in today's day and age. The other thing they did is they created a contract pharmacy. I will just very briefly describe this. The idea originally was, for a lot of the smaller community health centers, they said, look, I'm so small, I don't even have a contract, I don't even have a pharmacy in-house, so I don't get to take advantage of 340B. So they said, HRSA said, okay, cool, we'll let you contract. So you just contract with the local pharmacy down the street, you will pay them, they'll get a script fee, they'll pass on the 340B savings to you, we're good. And then in 2011, they said, actually, you can contract with as many as you want. And so now large hospital systems will have hundreds of pharmacies on a contract. I think I failed to sort of say exactly how 340B works. Effectively, they're able to buy at a discount, and then they're able to sell to Medicaid at whatever the Medicaid price is, Medicare at whatever the Medicare price is, but for commercially insured patients, they sell to us at whatever the commercially negotiated price is. So they bought the drug down here, they sell it up here. That plus contract pharmacy, plus the fact that more than half of the hospitals in the country participate, gets you to $66.3 billion last year in 340B at a discounted price. It's the second largest drug pharmaceutical program in the country based on net drug spending. It actually, bigger than Medicaid, it will actually be bigger than Medicare Part D in the next couple of years if it continues on this path. It will become the largest, and it is affecting every one of you. Next slide. So we've done a lot of work on this at the National Alliance. There's 3 ways in which you are being impacted by 340B and why you should care. Most of the time people have thought of this as like, it's just a fight between big pharma and hospitals. Like, what the heck do I care? Pharma has to pay less, hospitals make a bit of money, like let them deal with it. Because we are paying these huge deltas, that's why it's impacting employers. So when a 340B script gets written, this is all a little bit more complicated than what I'm going to describe, but basically it no longer flows through your PBM. So as much as we know that PBMs are not always passing on all of their rebates, they are passing on some of them, maybe even most of them. And so you're able to buy the drug at the rebated price amount. When it goes through 340B, that doesn't happen. You're paying the initial list price of the drug. Now for a significant portion of your patient population. So just in lost rebates, we worked with an organization called IQVIA. They found that in Washington state specifically, on average, purchasers are losing $56 per beneficiary per year. So take your number of covered lives, multiply it by 56. That's how much money you lost, most likely, in lost rebates. You don't see it on your claims because they don't have to describe that this actually went through 340B and not through your PBM. In Washington State, that's $218 million per year that employers are paying more than they otherwise would. And for all of you who represent states, Washington State, King County, City of Kirkland, City of Seattle, in total it's $30 million to taxpayers. We have found, I shouldn't say we, researchers that we work with have found that on average 340B hospitals prescribe more drugs than non-340B hospitals at similarly situated clinics. They prescribe higher priced drugs, and they mark up the price of their drugs. And it all makes sense, right? Because if you are in the game of making margin on the drugs, the more you prescribe, the higher price you prescribe, the more you mark them up, the more money you make. In Minnesota, I know I'm running out of time and I apologize. In Minnesota was the first state to mandate real transparency at the state level on 340B. They required all of the covered entities, so all the hospitals, all the community health centers, all of the rural hospitals, you name it, to actually disclose how much money they made on 340B. They looked at their overall amount of revenue, they subtracted out what they paid to contract pharmacies in script fees and all that stuff. One hospital, M Health Fairview, which is the academic medical center in Minneapolis, made $174 million net in 1 year, which was 150%, so 1.5 times more than all of the hospital's community health centers, Ryan White aid clinics, and rural hospitals combined. So if you ever talk to folks in the hospital industry about 340B, they'll be like, well, if you cut it, it's gonna harm our rural hospitals. To which you say, not really, they're not getting that much out of it anyway, it's gonna harm Providence. And let's be honest, who has the real power? Sorry for any Providence people in the room. It's not just you guys, it's everybody. And then we just came out just the other day with the report you see up there, the 340B premium. We just compared we had a researcher compare basically just prices, not drug prices, but just prices of large 340B hospitals and large non-340B hospitals. Large 340B hospitals are 7% more expensive across the board than non-340B hospitals. Outpatient prices are 20% higher at 340B hospitals. By the way, 340B is an outpatient drug program. And the total nationwide cost is $36 billion per year to employers. So people have sort of said, oh, it's costing us $36 billion per year. It's still slightly far because this is a correlation. I can't show causation in this report. But if we assumed that 340B hospitals were priced the same way as non-340B hospitals, other large hospitals, we would save $36 billion in the employer-sponsored market. Okay, that's my harangue. Next slide. Okay, so what can you guys do? First, don't be the Mariners. Don't do nothing. Don't sit an entire offseason out and do nothing and think you're going to make the playoffs this year. But that also means in the policy space. So step one, do something. First thing, and this is sort of in order, Cora did this cool thing at our annual meeting where she was like, you could do this, and then if you want to do more, you can do this. I'm not going to do that because it feels awkward. Cora did a great job. So first thing, stay up to date. Just sign up for a couple of newsletters and read them in the morning when you can. That's what I do. Politico Pulse does a great one. I'm sure there's local ones for Olympia. Cost Curve is run by this guy, Brian Reed. If you're kind of in the prescription drug space, it's brilliant. I read it every day. He also quotes me a lot, so I appreciate that a lot. I could talk to you about other places that you can stay up to date, but stay up to date. The next thing you can do, once you kind of feel like you're up to date and you're like, okay, I kind of have a sense of what's going on, engage with your coalition, engage with the Washington Health Alliance, and talk to them about your concerns and your views. WHA does an amazing job. They're one of our best coalitions. It's a multi-stakeholder coalition. You're all among friends here. But it's really helpful to engage with the other employers and purchasers in your area to just talk about the concerns. Next thing, and this is a harder one, but I know I've seen a lot of employers do this, engage with your government relations and policy staff. In the end, most of the time when I talk to people, Cora is an exception, but when I talk to most of the people that we work with on a daily basis, they're like, I would like to do something, but I don't have the authority to talk to the press. I don't have the authority to talk to members of Congress or state legislators. I'm like, no, you don't. I get it, and I don't want to get you fired. But go talk to the people who do have the authority. And the most important thing I found is bring them numbers, because in the end, they are going to be, if you are the chief lobbyist for Boeing, you're going to be focused on tariffs, you're going to be focused on taxation, you're going to be focused on things that are not necessarily the cost of healthcare. And actually, I will say Boeing is one of the few companies that does actually have a dedicated lobbyist in DC focused just on benefits, so credit to them. But bring them numbers and say, like, do you realize this bill could cost our company or our locality this much money? That starts to get them to say, okay, I'm gonna bring this up to my higher up and see whether this is something we can put on our agenda. And then, you know, the biggest one, come to DC, go to Olympia, actually start engaging. And one of the things that I found that helps, and I sort of arrived at this colloquialism just by accident, you don't need to own the solution. Most of you, if you're not a policy person, are probably not gonna say, like, I don't know the name of the bill. I don't know I don't know the members of Congress, the state legislators themselves. You don't need to do that. You have people. You have Washington Health Alliance. You have the National Alliance of Healthcare Purchaser Coalitions. You have others. You need to own the problem, which is to say, you need to come and tell your story and say, here's the challenge we are facing. I'm trying to write a new contract. I'm going out for an RFP, and here's the problem I'm facing. I'm not able to get access to my data. I used a story that Cora gave me in my testimony on Capitol Hill. Cora is doing an RFP on PBMs, still could not get, despite large size and being very aggressive, could not get a PBM to say, I will provide you with claims level rebate information. I was able to say that on Capitol Hill because Cora told me that was the case. I didn't mention her name in the testimony. Employers don't know what they're paying for drugs. And guess what? You know how the number of eyes of members of Congress who were like, employers don't know what they're paying for drugs? And so you don't need to own the solution, you just need to own the problem. And that goes an enormously long way because then it empowers people like me to be able to say, here's what employers are experiencing day to day, and here's a bill that will help, or here's a bill that will make it worse, or here's a regulation that you should consider. It's easier than you think, it's a lot more fun. I will end with, I don't have like a quote, but with actually something that I heard from the head of benefits from Ford Motor Company. So, big job, she's been doing a lot of work, she's amazing. And she said the highlight of her career was coming to a National Alliance conference and going up to Capitol Hill and talking about what she's doing. Like that was the highlight of her career, which I was sort of like, your career is not as cool as I thought it was. But for her it was. So I would say, if you're interested, talk to Drew, talk to Denise, talk to me, come to DC, be part of this process. Thank you, I apologize, I went a few minutes long. I'm assuming I don't have time to take questions, so I'm going to turn it over to Drew. I will be over here if you guys want to chat.
A couple minutes ago, the M's were ahead, but I don't know what happens now. So thanks everyone for coming. You can grab folks and talk to them afterwards. Some of the information might be helpful for you. Some of it's maybe hard to hear, and that's part of having the discussions and the challenges that we have to face in front of us. Great having everyone here. Thanks to all the speakers. Thanks for you guys hanging out and staying with us all day. That's pretty impressive. And it's sunny outside, so I don't know what that big thing in the sky is. So that's fantastic. Anyway, thank you very much.